to empty the content.
Se abre a través por la línea alba y se ponen las viseras en la mesa al costado. Luego se abre, se abre el órgano para ver qué es lo que se encuentra dentro, ¿no?
We then reduce the problem and correct the problem, and then it goes back in the recovery box.
Y una vez que se corrige el problema, vuelve a la sala o al box de recuperación postquirúrgica.
We help the horse for the recovery. Sometimes we don't, sometimes we have to stop recovering, so it depends.
Algunas veces se ayuda, se apoya en la recuperación del animal y a veces no, eso se interrumpe, dependiendo de cómo vaya respondiendo el animal.
As you see, I'm very happy today that I still have some sunshine here in Peru, because when I go back in France now it's the winter that is coming, and sometimes we have to operate by minus 10 degrees, something like that, so it's very cold.
En Francia hace bastante frío y en ocasiones tiene que operar bajo temperaturas muy frías, entonces comenta que en realidad no tiene prisa por regresar a Francia porque acá todavía hace calor.
So the recovery box, you see the ground, the walls, everything is soft so that the horse cannot injure himself.
En el box de recuperación, las paredes, todo se tiene cuidado que sea suave para que el caballo no se lesione a la hora durante ese proceso de recuperarse la anestesia.
So it's only when the horse is standing, when it has recovered, that I will talk to the owner and explain to the person what happened, what was the prognosis. Usually, all that thing takes about, since we use the horse and he recovers, between 3 and 4 hours. I never call them before he's standing, because we can have accidents during that period. And then we call back the owner and we tell what we have found and what's the prognosis.
Normalmente todo el procedimiento desde que se induce la anestesia dura entre 3 a 4 horas y él normalmente no contacta de nuevo a los propietarios o los responsables del animal hasta que el animal esté despierto y esté parado en el box de recuperación, ya que en un periodo antes de que suceda eso podrían haber problemas o complicaciones, entonces tendría que cambiar lo que le está diciendo a los dueños.
After that, we put, once he's recovered, so we put the horse in another box in the stable for intensive care. And intensive care, it's usually minimum 1 day, but it can be up to 4, 5 days for small, usually small bowel problems. Large bowel problems, usually the intensive care is much shorter, it's like about 24 hours.
Luego se pasa el caballo a un box de cuidados intensivos que puede estar, dependiendo si es que ha sido una lesión o un problema no tan grave o leve, de 24 horas hasta 4 o 5 días.
Yeah.
Sí, 4 o 5 días.
Okay, now let's go to today's topic. And let's start with a little bit of culture again. And just to tell you that in Belgium, if we don't have coffee and chocolate in the morning, the day is very difficult. And you see, that's another thing I've learned, that is South America or or Africa is not there. We think in Europe we have big problems because we don't have cacao and no coffee. So we have a lot of shops with chocolate and coffee.
Comenta que en Bélgica, para empezar bien el día, uno debe tomar café y comer chocolate. Por eso es que tienen un montón de cafés y sitios que a veces es un problema en otros países, pero no en Europa.
Okay, so let's start now with diagnosis of foot pain or a distal limb problem. Of course, what I want to show you is a little bit like we did yesterday with the colleague. It's more to give you a pathway how to come to a good diagnosis of a foot problem.
El tema de ahora es como el diagnóstico de los problemas en el pie. Se va a pasar un poco en lo que se explicó en la charla del día anterior.
So we start, of course, with the physical examination. Try to recognize any type of external abnormalities. You see here there's a fistula, problems in the white line, etc. And
bueno, se empieza siempre por el examen físico del animal. Primero se evalúa si es que tiene alguna alteración en la parte externa, como se veía en la diapositiva anterior, en la segunda fotografía en el medio, en la línea blanca o en los alrededores del casco, si tiene alguna lesión visible.
That physical examination and should include some physical tests, like here we try to see if there is a problem with the flexor tendon, because the flexor tendon attached to the third phalange. We do the hoof testing also with pressure here. We are going to trot the horse on a hard ground and a soft ground.
Este examen físico también involucra otro tipo de exámenes. En la primera fotografía, donde está el caballo blanco sobre una pequeña rampa, se está probando el funcionamiento del tendón flexor. En la segunda fotografía, a la mano derecha, en la parte de arriba, se está probando el casco en sí y la sensibilidad, si es que existiera una sensibilidad en una zona u otra. Y en las fotografías de abajo, el caballo se hace caminar el caballo para que puedan salir a la vista algún problema o algún tipo de cojera o algún otro problema.
And for instance, this horse has some pain. By normally a normal horse, the leg should be straight and perpendicular to the road. And in this case, you see he's showing some pain.
En esa fotografía que señala, el caballo siente dolor. Normalmente la pata debería estar perpendicular, derecha y perpendicular al piso, y en la fotografía se puede apreciar que no es así.
The physical examination include also flexion of the limb, and then repeat trotting. Trotting also in a circle, on the right, on the left.
Parte del diagnóstico del examen implica la flexión de todo el miembro y que y trotar, se tiene que hacer que el animal no solamente camine, sino que trote en círculos y hacia la derecha y hacia la izquierda para identificar en dónde se puede encontrar la lesión.
So that's what every vet needs to do. Everyone should do that. That's the basics. And then, when you have if you get specialized, or if you have subtle limbs or things like that, you can use another instrument that we use in our clinic. It's the Lanus locator. And I won't go in depth in this, but I want you that you are aware of that technology of Lanus diagnosis. I'm just going to share you 5 slides about that subject.
Eso, lo que había mencionado anteriormente, es lo que debería hacer todo veterinario al realizar el examen físico, pero si uno quiere realizar un examen en más detalle o especializado, hay en la diapositiva anterior mostraba un aparato que nos permite.
No, but I will show you.
Es una herramienta que ayuda a localizar exactamente dónde se encuentra la lesión, la cojera, y él no va a entrar en detalle ahorita de qué se trata, cómo funciona, pero va a mencionarlo en las siguientes 5 diapositivas porque considera que es importante que sepan que existe este tipo de
So, what I want to just indicate is that instrument, I'll show you another picture later, but is assessing the asymmetry of the vertical movements of the front legs and the hind legs, and it is 10 times more sensitive than the human eye, which means that normally when we do a lens examination to see the head doing this or the hind leg going up and down, the minimum we can assess is a 2 centimeter difference between the right and the left. That's a human being is approximately, we see it when there is 2 centimeters, then we can see it properly. The machine see a 2 millimeter difference. So it tells you how refined we can go in the lens examination of a horse.
Esa tecnología es 10 veces más precisa que el ojo humano. Lo que hace es medir la simetría entre los miembros, los 4 miembros del caballo, y normalmente cuando el caballo camina y uno nota de que hay una cierta variación entre un miembro y otro, el movimiento de la cabeza, el movimiento de las patas en sí, pues el ojo humano puede detectar una variación, una asimetría a la hora de la pisada de hasta 2 centímetros. En cambio, esa tecnología lo detecta hasta en 2 milímetros, es 10 veces más preciso que lo que una persona podría detectar.
And so we use it either in very subtle layers. The trainer tells you, my horse was bad on the left or bad on the right, but you cannot really see something. Or in cases where it's a multiple leg lameness that happen, that it's 2 or 3 legs, we call it complex lameness. It's also to really assess the answer to a flexion test or to a local anesthesia, because there also it's just a little amelioration that we have. And then, I finished this and I'm sure you will remember. And then, what's also very interesting is the long-term assessment. So I have a horse, you do the diagnosis, and then you ask him to come back 1 month later. And then with the instrument I show you how it looks like, you just compare numbers, you compare objective data. And sometimes I'm not there 1 month later, it's my colleague, because I'm in Peru, so he's doing the post-op exam, the post-lens exam. And what he will just do is to compare the numbers, because probably that me as a human, I don't have exactly the same assessment as my colleague. We don't have the same assessment, but that's much more objective.
Ok, explica por qué esa tecnología es mucho más objetiva. Primero que me permite no solamente me dice si es que hay una variación entre los miembros, o sea, hacia la derecha o hacia la izquierda, donde se encuentra la simetría, sino que te puede detectar si es que hay una lesión en más de un miembro, más de una. Eso se le conoce como las cojeras en las lesiones complejas. También me permite evaluar.
When you look at anesthesia, and then you can see before and after.
Okay, también me permite evaluar cuando realizamos exámenes o procedimientos con anestesia local, me permite evaluar antes y después, que es una técnica que se usa también para detectar diagnosticar la lesión. Y normalmente lo que ellos hacen es, una vez que se hace el primer examen, el examen inicial, se pide que el animal regrese en 1 mes y se vuelve a hacer una evaluación. Y eso es bastante más preciso y más objetivo, porque lo único que uno tiene que comparar es los números. Me da unos resultados según números en donde se encuentra la simetría, y lo único que uno tiene que hacer es comparar los números y ver si es que ha habido una mejora o no.
So, the way it works is that we are going to, and maybe I show it now. Sorry. So, there will be you see these little electronic device that we put and the third one here. And what we do, that instrument is measuring the impact lameness and the push-off lameness, and in fact is measuring the difference, we say asymmetry, between the left and the right. Okay? And then we have different, I will not go in details, but it gives you different data that comes like this on a graph on the computer. For instance here, the front limb lameness.
Nos explica que se colocan unos sensores en la cabeza, en los miembros y en la grupa del animal, y lo que mide es la cojera, bueno, la reacción y el impacto y la simetría, bueno, tres cosas básicamente. El impacto que tiene a la hora de movilizarse o flexionar, la reacción que ejerce o la fuerza que ejerce el miembro o el animal, y la simetría, si es que un lado o algún hacia la izquierda, a la derecha, adelante, atrás, hacia donde se encuentra una mayor reacción. Eso después se puede ver en gráficos como estos, que me explica en el azul la reacción, el impacto, en el amarillo la reacción que está haciendo el animal.
And so you have that for the front leg, but again also for the hind limb. And all the exams are doing at a trot. So we trot the horse 2 times on the road, and it's a wire-free instrument that sends all these data into the computer. So you just do one way and back. That goes into wire-free. Then you say stop, and then the machine gives you the results.
Entonces, en el anterior era los resultados del miembro anterior y esos son los resultados del miembro posterior. Todos los exámenes se realizan cuando el animal está trotando. Trotar de ida y de vuelta, y eso basta para que la máquina me suelte los resultados que necesito.
And so then it gives you an analysis report like this, explaining what is happening really in the horse, and then we have all these objective data here. Again, this exam should be in addition to your normal clinical exam. It really helps you for very refined things.
Esta es la hoja con la información que suelta este examen, y recalca que es importante que este examen es complementario al examen físico que tiene que realizarse de rutina todo veterinario.
Because it tells you which limb is involved and how much it is involved, but it doesn't tell you the location on the limb.
Esta tecnología te dice qué miembro está involucrado, pero no te dice exactamente en qué parte del miembro se encuentra la lesión.
So once you know the limb, then either it's evidence that you see an abnormality on the limb, a pain at pressure or something like that, but usually it's not the case. So you need to go to local anesthesia, and the first anesthesia being the pulmonary distal nerve block by injecting a couple of milliliters of lidocaine on the distal nerves just above the foot, above the coronary vein.
Entonces, una vez que ya se identifica el miembro, el siguiente paso es localizar la lesión a través del bloqueo de los nervios con la anestesia. Lo que se hace, la primera anestesia que se utiliza es bloquear el nervio digital palmar con una pequeña cantidad de lidocaína.
And then slowly, if the horse is not answering to these, the pain is not going away with the local anesthesia, all these images of the local anesthesia are taken from a book that you probably all have about this, so it's not my pictures here. But you see that the next step we go up and we do the abaxial sesamoid nerve block, and of course then the region that is anesthetized is bigger, and so slowly you go up and up and up.
Le explica que si no hay una respuesta del animal, si sigue habiendo un dolor, entonces el siguiente paso es moverse más hacia arriba, aplicar una siguiente dosis de lidocaína en el nervio abaxial para bloquear una mayor cantidad de nervios.
Well, so what I want to show you here, once you have done the nerve blocks, after that you have another type of anesthesia that you can do. It's the joints and the bursa. Then you inject, like here, straight away into the P2P3 joint, or like here you see under X-ray control. Okay, you put the needle into the nerve bursa, and then you can get a little bit more precision about your anesthesia.
El siguiente paso podría ser realizar la anestesia dentro de las articulaciones. Se puede hacer dentro de la bolsa navicular o en realidad en cualquiera de las articulaciones dentro de entre los falanges. Y se puede hacer eso a través de ayudándose con otras técnicas como los rayos X.
And what I recommend you, if you decide to do your latest examination a little bit more sophisticated and you use these anesthesia, it's to repeat on a dead leg. You know, you just take a leg and inject methylene blue. So just take a syringe with a little bit of methylene blue and do, if you were in a clinical situation, and do your local anesthesia. And after that you dissect and you see if your blue is on top of the nerve or into your joint or into the bursa. That's something that everybody can do at home. Take the book, it can be the latest examination of Adams or Sudai, there are many books, and then start, you know, in November, let's say, with a digital nerve block and decide until it's good. Then the next one. And what is good is that you will see by putting that stain on the nerve, then you will be happy once you will do it on the clinical situation, because you know exactly that you know that you are in a good place. And when you have a negative answer, so that the anesthesia doesn't work, you know it's not because your technique was bad, it's just because that's not the location of the pain.
Lo que él recomienda para practicar y asegurarse de que uno está haciendo la anestesia correctamente es tomar una pierna, a manera de práctica una pierna de un animal no muerto, ¿no? Y practicar poniendo en vez de lidocaína azul de metileno. Entonces uno puede practicar inyectando en los diferentes puntos, después diseccionar, abrir la pierna y ver si es que efectivamente llegó a poner la inyección en el sitio adecuado. Así uno sabe que cuando está haciendo el examen ya con un animal vivo y el animal no responde o sigue sintiendo dolor, uno puede estar seguro de que es por la lesión en sí y no porque uno no ha hecho la anestesia correctamente.
Next step, once you have localized the lameness, then you start. The first thing is diagnostic imaging. There also, don't do X-rays if you are not sure that you will do good X-rays, and if you don't do all the projections. So it doesn't bring you anything, just do one lateral projection of the foot and say there's nothing. You need to do all of them, the 5 of them, if you want to assess what's happening inside. Good quality X-rays and all projections. Because normally, to say that there is something, you should be able to see it on minimum 2 projections. Okay? Otherwise, it's probably an artifact or something else, or nothing.
También el siguiente paso es diagnóstico por imágenes, y él recomienda de que sí, es importantísimo realizar buenas tomas, ya que si no, en realidad no vale la pena. No es suficiente solamente realizar una toma, tomar una radiografía de un solo ángulo, ya que eso no dice mucho. Mínimo se debería tomar 2, y lo recomendado es tomar las 5 vistas para realmente saber si es que se encuentra ahí la lesión o no.
So I would say that in 90% of the horses that comes from a lameness of the foot, we do X-rays. So it's really a basic complementary exam. We rarely go straight away, for instance, to ultrasonography, because ultrasonography in the past, etc., if you feel that if there's a soft tissue problem, then you can go straight away to ultrasonography, but it's very rarely the case, so it's mainly deeper. So if, of course, you have a tumefaction, then you do the ultrasound, the scan. But to be honest, it's just like in 10% of the cases that we do the scan first, usually it's X-rays.
En el 90% de los casos se realiza una radiografía, se hacen las tomas de rayos X, y solamente se usa el ecógrafo cuando se cree después de una radiografía, y cuando se cree que la lesión, o se está más o menos seguro de que la lesión es de tejido blando. Podría ser también si es que uno tiene una zona edematosa, que se recurre antes de los rayos X a la ecografía.
Because we are talking about X-rays, now I want to show you a technique that is important when you want to assess a laminitis. That's what we call digital venogram. So what is it exactly? You take your horse standing, you put a tourniquet, a little catheter, and you will inject a contrast fluid into the vein, and then you will assess by an X-ray. You see, you prepare your X-ray machine, and here's the cassette. And as soon as you have injected, you do the X-ray. And then we will assess. The next slide, I will show you how to assess.
Una técnica que él recomienda para los casos de laminitis es el venograma digital. Lo que se realiza es poner un vendaje en el miembro, y luego se inyecta una sustancia con contraste, e inmediatamente después de inyectar esa sustancia se toma la radiografía.
And so you see, you do 3 X-rays, a lateral medial one here, dorsopalmar, and the skyline. Dorsopalmar and skyline. And then what you want to see, that's, you see the contrast fluid going to the vein, then going everywhere, you see. So we have a very good vascularization of the foot, also here at the coronary band. And if I compare here with a horse with laminitis, look, the contrast fluid is here, and nearly nothing is coming here, and definitely nothing there. So don't spend your time treating that horse. It's finished. Euthanasia. And that's, I think, a very, very useful technique for these cases of laminitis, where they are very painful and they have a fast rotation or a fast thinking. If you have a fast rotation and that there is no more blood or no more vascularization, it will not come back. Okay, so you just spend your time treating for nothing.
Lo que compara es en la fotografía de la izquierda se puede ver la sustancia en contraste que llega a todo el miembro, y hay una buena vascularización. En cambio, en la foto de la derecha se ve que la sustancia en contraste llega más que en la parte superior, y el resto del dedo, incluso dentro del casco, no hay la sustancia, por lo que no hay una buena irrigación. Eso se puede dar porque hubo una rotación muy rápida o muy brusca de entonces se ha cortado la vascularización y él indica que no vale la pena entonces tratar a este animal. Incluso sugiere que se debería considerar la eutanasia porque por más que uno lo trate, no hay vascularización del miembro, entonces no va a haber una mejoría.
After that, as I said, we can do ultrasonography. Like here you have the P2, P3 joint, you can assess what's happening there, eventually if you have synovitis and things like that. But the distal limb, there is not a lot to see with ultrasonography because of the horn.
Luego se puede ver acá las fotografías, compara la derecha con la izquierda. Bueno, había mencionado antes ya que se tiene que hacer luego de la vida.
Oops. Okay. Other, what we call advanced diagnostic imaging technique, is the thermography, which nowadays it's not used anymore because there are much too many artifacts from the outside temperatures and it takes a long time to prepare. So personally we don't use it anymore. We have been using it about 15 years ago, 20 years ago. But I know some people still do it, but it's very difficult to really have a good assessment. Scintigraphy, then you see that's a scintigraphic machine here. You do one limb at the same time, and then you get images of the hot spots in the distal limb, or in this case it's the knee, but you do the same everywhere on the...
These hot spots are
No, these are, so the principles of scintigraphy is to inject technetium-9090 Hen, which is radioactive material that is bound to a bisphosphonate, and that bisphosphonate goes where there is high bone remodeling, and that makes a little spot, a little white spot. If there is no remodeling, no hot spot, then you have a black hole. So it's a way to see if you have high remodeling or no remodeling, which is not good either.
Acá comparan dos técnicas, la imagen de la izquierda es una termografía que se usaba bastante hace 20, 15 años, pero hoy en día no, porque me da lugar a por factores externos puede haber una mala interpretación de la técnica. Y la fotografía de la mano derecha es la citografía, que se realiza en un miembro a la vez. Lo que se hace es inyectar una sustancia radioactiva que va a buscar los sitios donde haya habido una remodelación en el hueso. Entonces se va a notar en la máquina, en la computadora en todo caso, como puntos o como locales o manchas, ¿verdad? Hotspots blancos, y ese es donde ha habido esta remodelación del hueso, ¿no? Cuando no hay nada, se muestra todo como negro.
But probably the best instrument in that new diagnostic imaging techniques is the MRI. MRI of the foot. Why? Because these are images of the MRI. It gives you image of the soft tissue and of the bone at the same time. So the way it works, we bring the horse into a specific room, and we have a coil that we put around the leg and the region we want to assess, and then we'll get these type of images.
Este método diagnóstico es la resonancia magnética, indica que es el mejor método que se tiene actualmente. Es muy parecido al humano, se trae al caballo a esta sala especial y se vuelve el miembro que se quiere diagnosticar y se obtienen imágenes también.
MRI, this is a picture with MRI, is very good to assess the natural bone degeneration, digital flexor tendonitis, collateral dermatitis, traumatic arthritis, P3, bone process, impaired ligaments, so many things in that region. And since MRI exists, we have increased our quality of diagnosis about like 300%, which means now, with much more precision, we can give much better treatment, more adapted treatment. Before MRI, if there was a pain in the foot, and with a hyperextension test positive, usually we would say, okay, navicular bone disease, navicular bone syndrome, and even if there was nothing on the X-rays. And nowadays, that doesn't exist anymore. We have much more differential diagnosis possible. And then we can adapt the recovery, etc. of the nerves.
Desde que se tiene la resonancia magnética, anteriormente normalmente se diagnosticaba mucho lo mismo, ¿no? Enfermedades del auricular, a pesar de que no se encontraba nada en las radiografías o incluso en las ecografías. Ahora, gracias a la resonancia magnética, tenemos muchos diagnósticos diferenciales, ya que es mucho más preciso. Eso nos permite tratar directamente cuál es la lesión. Menciona que algunas de las lesiones que pueden diagnosticarse con este método es la degeneración del auricular, tendinitis, dermitis, artritis, etc.
What I want to emphasize is that a normal MRI of one region takes about half an hour to 1 hour. It means that MRI is not a screening instrument. It's not because he's laying the left front leg that you will do MRI from the whole left front leg. That would take like 2 days. So you need first to do your normal examination with all the local anesthesia, do the X-rays, you don't see anything on the X-rays, you know it's on that region, let's say the fetlock, then you will do MRI of the fetlock. That's all. Okay, so it's not a screening. It should be, all your exams should bring you to exactly find something at a precise location where you don't have anything on the X-ray or on the normal ultrasonography.
Indica que normalmente uno tiene que efectuar todos los exámenes anteriores y localizar el área donde se encuentra la lesión. Y una vez que se tiene se ha ubicado el área, es solamente en esta área donde se realiza la resonancia magnética. Y este procedimiento puede tardar entre media hora y 1 hora.
Also, anybody cannot say, I will read an MRI. It's very difficult because there is a lot of artifacts, a lot of variation in the quality of the images. So the people tell me, bought an MRI and then he's reading it. That's impossible. You need a lot of training to be able to read an MRI. So be very careful, and it should always be related, the images you have, with the clinical exam to see if it's of clinical significance. Because you can see what you would think is a problem on MRI, and then the clinical symptoms doesn't go with that thing that you see on MRI. So again, it's a complementary exam to your clinical exam.
Le da énfasis a que la resonancia magnética es solamente un complemento a los exámenes previos que se han discutido. No cualquiera puede leer una resonancia magnética, necesita de todas maneras pasar por una capacitación, entrenarse para entender e interpretar los resultados.
So, take-home message concerning the diagnosis of foot pain. Definitely, it stays the most common location of lameness, problems in the digit, problems in the foot. It's usually a complex bone and soft tissue structure. Often you have a bone problem but with an inflammatory reaction of the soft tissue around.
El mensaje principal que quiere que se lleven es que la mayoría de veces las cojeras se dan en esta zona, en lo que es el pie del animal, y que normalmente no son lesiones, o mejor dicho, son lesiones complejas que comprometen el hueso y el tejido suave, bueno, el músculo, nervios, etcétera, que están rodeando el hueso.
It's a region that sustains massive weight-bearing and ground impact. That's why we have so much problem. And to diagnose what's happening there, you need to be logical, staged, and go through, like we did yesterday for a colleague, you know, from 1 to 15, 14. It's the same here. We go from the external physical exam, neurological, etc. Don't go straight away to X-rays, for instance, because you cannot believe how much X-ray abnormalities you can have in a foot without any clinical symptoms. So the clinical relevance of a problem on the back, on the foot, anywhere, okay, needs to be related to the clinical symptoms. There are many, many, many things that you can see on the X-rays. You would say, wow, that horse is not able to walk, okay, but they are just not significant.
También en el punto número 3 dice que esta zona, el pie o las manos, los miembros posteriores y anteriores, son las zonas donde tiene bastante estrés porque soporta el peso del animal y donde se da el impacto con el suelo. Y en el punto número 4 dice que para diagnosticar los dolores, estas lesiones en los pies y manos del caballo, uno tiene que ser lógico, seguir un proceso detallado o paso por paso de lo que se tiene que hacer sin saltar de un proceso, de un diagnóstico al siguiente, y tiene que hacerse por un proceso de eliminación. O sea, lo que sugiere es siempre tiene que tomarse en cuenta el orden, primero el examen físico, el orden de todos los diagnósticos, pruebas diagnósticas que se tienen que hacer, y siempre tienen que relacionarse con cómo se encuentra el animal. Pueden haber casos que las radiografías muestran una cosa, de repente uno pensaría que el caballo no puede caminar, cuando en realidad el caballo presenta unos signos que no necesariamente los muestra en la radiografía.
It looks like you have more things to say than I have to say. It looks longer in Spanish. Concerning the process of elimination, it is very important. You have your exam, it's in the foot, I do the X-rays, okay, nothing on the X-rays, so the bones there is normal. And then because you're behind the horn, then yes, I will recommend an MRI to assess, for instance, that little ligament there that may have a tear or something like that. See, so elimination, huh? So it's staged and elimination, and she said that before, and I completely agree with her. Okay, so just to show that one of these days probably will be in charge of high jumping horses. That was the last competition in Lyon in April. That was the final of the World Cup. And of course, these horses have very subtle lameness. And you need to find very early the problem, because eventually you need to reduce a little bit the training, but not too much, because they need to go to competition. So you have the basic diagnostic lameness, and then slowly, okay, you will get, after a few years, when you're happy with your basic lameness examination, you get deeper and deeper in it, and then maybe you will have this type of clients, and then you should not make a mistake, because these horses have really big value. And that one, for instance, is worth 12 million euros, that horse, specific horse. So you see then you need to be very precise and give good advice.
La fotografía muestra un caballo que vale 2 millones de euros. Es una foto en la final de votación. Y lo que señala es que uno tiene que saber ser bien preciso en el diagnóstico, porque ese tipo de animales valen bastante, ¿no?
2 millones de euros.
first part. Yes. Sorry, there's a question. Two questions. One question, two parts.
The first one is, how much can these machines cost? Because I'm pretty sure they are not available. So they have an idea.
Okay, the latest locator is 12,000 euro. That's the latest locator. And MRI, nowadays, either you buy it, and that's all together with the room, it's 800,000 euros. But nowadays, what the company is doing, there's only one company doing MRI for horse, okay? And they have no system of renting. So you build the thing, but the machine is still there, and then you can rent. So it's cheaper. I don't know exactly the price, but it's possible. But again, before to come today, because today my goal was to show you where we are today and where we go, and where you have to go. Still, don't jump on the MRI. You first need to be very good, just in X-rays, and then it will come. But you have to be aware that eventually you will have to send the wards, maybe in Argentina. I'm sure they will have one of these days. And then you need to be aware of the technology, what it brings to you, and when you receive the report, to be able to discuss with your client. Because we were the first MRI system in France, and of course it's only referred cases. It was not all cases. It was the practitioners all around France were sending it to us, and then we're giving them their report with what we think it was back to the vet, and then the vet needs to do what I'm going to do now. And that's why it's important to continue to read nowadays about new orthopedic shoeing and new treatments, because since not 5-10 years we have new disease that we are able to recognize. And so you should, as a vet, be able to treat them as soon as the MRI guy will tell you, okay, it's an impaired ligament problem, for instance. What should I do? And that's why it's important to be up to date in the technology and up to date in the treatment.
Okay.
Second part.
For the MRI, do you have to put the horse under anesthesia?
No, that was a standing. Have you seen? The horse was standing. It's just sedation. It's a stand. So you have two options. You have general anesthesia MRI or standing MRI. Standing MRI offers the possibility to go to the carpus or to the tarsus. Not higher than that. General anesthesia, you can go high. That's the big difference. In fact, why? It's because higher you go on the limb, more little movements you have. And the little movements makes bad damage. And so that's why you need general anesthesia. But we have decided in my clinic not to go for this, for the only reason that, in fact, the things that we need to find higher are, so few. We have good scan and X-rays for the upper part of the limb. Our major problem is in the foot. And that's why for us, and then it's less expensive to buy such a material than general anesthesia one. And you don't have the problem of general anesthesia also. Any other questions about diagnosis? No? This picture is just to say that maybe if there is a circus around, they might come with nothing to you. And it happens to me 2 times now that we had to do a diagnostic examination of the foot of the elephant. And then I tell you, with your X-rays, you see a lot of artifacts in there. But yes, and then again, you need to do the same. Of course, you don't do flexion tests, but you need to try to be logical and see how it's laying, is it when you push on it or not, and then after that you do the X-ray. So it can happen to you as a large animal practitioner that they bring you an elephant.
Bueno, mencionan que le ha pasado que ha llegado incluso elefantes a la clínica. Claro, uno puede hacer las evaluaciones que le hacen caballos, ¿no? Pero uno tiene que estar siempre preparado.
So what I'm going to do now, I have to cut a little bit my presentation. So so that we can go through everything. Which of these diseases would you like me to talk about? Maybe should I start with the two first ones, which are very important?
No, va a tener que recortar un poco por cuestiones del tiempo de la presentación, entonces quiero saber qué lesiones les interesa más hablar. Él sugiere las dos primeras, que son los abscesos.
You know what? I will try. Let me find. Okay. Let's see. Abscess? No? No abscess?
No.
Oh! Okay, let's try. Let's try to do something. Okay. First, when we talk about an abscess, either it's a subsolar abscess, an abscess underneath, or a hoof wall abscess. And as you see in the diagnosis, the grade of lameness is approximately the same, but you can have a low lameness grade when it's under the hoof. Okay? Sometimes it's less under the wall of the hoof. Okay? It's sometimes less painful.
El grado de cojera que se tiene cuando tienes abscesos en la pared del casco es ligeramente menor que cuando se encuentra en la suela o otros tipos de abscesos.
What you should understand, the importance of pain comes from the pus that makes a little pouch between the bone, which is a hard tissue, and the bone, which is hard also. And that's why it's very painful, especially in the subsolar abscess. Because when it's under the wall, then the pressure can go up at the coronary band, where you have some soft tissue. And that's why the pain is less important.
Indica que en esos abscesos subsolares causa más dolor, lo que hay más cojera, porque se encuentra el absceso entre dos superficies duras, que es el hueso y la suela del casco en sí. Entonces, en el otro tipo de absceso en la pared, como se encuentra el absceso contra un tejido suave, entonces el dolor es menor.
And you see, usually the horse will be like that, with just the two touching the floor, and sometimes you will see even lift the limb. Okay, it's two and lift. And that's usually because there is a subsolar abscess. Okay? Now, of course, you can use the hoof tester, where you have the pain, and when it's subsolar it's drunk, you just remove his leg. But you don't have edema of this part of the leg when it's subsolar. And sometimes, when it's a hoof wall abscess, then you start to have inflammation here. But a symptom before to have that edema in the vascular region, just look properly at the coronary band, and you will see that normally all the hairs of the coronary band are, goes down. But where it's going to open, the hairs are like this, It opens instead of having that like this. It goes like this. And usually you can see that like a couple of days before it opens and the pus comes out.
Bueno, primero indica que a la hora de hacer el examen para ver si hay dolor o no, en los abscesos que se encuentran en la suela normalmente hay mucho dolor, y en los de la pared no, o a veces incluso no hay dolor, y indica que en los abscesos en la suela normalmente no se va a encontrar una inflamación o una distensión de la piel, ya que no tiene hacia dónde crecer, no tiene hacia dónde expandirse, y lo que indica es que se puede ver, esa inflamación se puede evidenciar cuando justo en la corona alrededor donde empieza el casco, el pelo o el pelaje del animal comienza a abrirse y distendirse justo unos días antes, un par de días antes de que salga el absceso.
Exacto. Diagnosis, coronary vein inspection, remove the shoe, and when you remove the shoe, it's nail by nail, and assess the nail. Don't look for yellow pus, just look for humidity. The nail should come out dry. If the nail is slightly humid, that's where the abscess is.
Indica que a la hora de retirar los clavos del caballo, entonces lo único que se tiene que hacer uno por uno y uno no debe esperar encontrar la pus, sino basta que se encuentre que el clavo está húmedo para saber que el absceso se encuentra en esa zona.
Then you do the debridement at the place where it's painful. And sometimes the horn is so hard that I use a Dremel, so electric device, to remove slowly the horn.
Lo que él hace a veces es usa
in electric device.
Claro, no me acuerdo la palabra. Un torno para debridar toda la zona que le permite poder sacar la lesión sin hacer más daño, ¿no?
Don't hesitate to do local anesthesia of the foot, okay, so that you can really work properly. Because when you want to debride an abscess, you need to go to the blood, okay. And then if you have blood, it means that you're touching the podophyll, and the podophyll you have innervation there, so you have vessels and innervation. And of course, when you will touch this, it can be painful. So don't hesitate to make a nice local anesthesia for better work.
Indica que si considera necesario se puede usar anestesia local, ya que a la hora de debridar la zona, de todas maneras, lo que uno va a buscar es que eventualmente salga un poco de sangre, ¿no? Y esto va a causar dolor, entonces indica que es necesario incluso usar la anestesia local.
Now, yesterday we have talked together about how to prepare the foot, so I'm not going to talk about that anymore. But nowadays, when I don't, for normal abscess, a normal foot abscess, without involvement of other structures, I don't give any systemic antibiotics. I just do, when I do the work, once a local regional antibiotherapy, either on the standing horse or in general anesthesia. And you see, try to be familiar with that technique, it really helps you a lot. And in fact, it's more work the first day you are with the horse, but then you don't need to give more treatments afterwards, etc. So it really, it's like a big veterinary job the first day, and then it's much more comfortable after that. Local regional, gentamicin. Yeah. But you can use other ones. So there are a lot of antibiotics you can use in casein, but for instance in France we're not allowed because it's a product, an antibiotic that is reserved for human medicine, difficult cases. And so, as you see, you have to adapt with what you have, but there are many recipes of antibiotics you can inject.
Él menciona que normalmente lo que no usa antibióticos, o mejor dicho, usa antibióticos de manera regional, no receta un antibiótico sistémico, receta mucho mejor y lo que normalmente usan son gentamicina, podría usar amikacina también, pero en realidad depende de lo que uno tenga a la mano.
Now, look at these pictures. You find a lanus localized in the foot. The hoof tester, usually it's like, painful everywhere. And so it's a subcellular abscess, you localize it, and you start to debride where it's more painful. Okay, that's what I've done here. I started there. But in fact, if you look at this, look, there's like a little black line. It's white and then pink. Black line. In fact, the abscess is there since many days. And there's already a space between the podophyll, which is pink, and the chemophil, which is white. Everywhere where there is a space, you need to remove, because that's a new location of abscess. It will recidive after that. And that's why you should not be afraid of resecting nearly 90% of the sore, like here. But listen now and look. Here I have perfect contact between the white and the pink. There I know that the bacteria and dead material will not go underneath. Now I can start a new healing process of the foot. If you just do a little bit because you're afraid of the blood coming out, the work will be badly done, and 2 months later, or sometimes 15 days later, it will have another layers, another abscess. So be aggressive in your debridement until you see a perfect contact between podophyll and chemophil.
Hace énfasis en que siempre tiene que remover todo lo que lo sigue. A la hora de debridar se tiene que remover bastante. Mencionaba en la fotografía a la derecha arriba que se puede ver una línea negra que separa la parte blanca de la parte rosada. Entonces él dice que si uno deja, por tener miedo a de repente que salga demasiada sangre o empeorar la lesión, si uno deja que esa materia o esos espacios queden ahí, entonces es casi por las puras, porque es muy probable que vuelva a ocurrir la infección. Tiene que quedar siempre todo como en las fotografías de abajo, que se vea rosado y que no haya materia.
If the bone is involved, if it goes down to the bone, curette and resect the bone. You would not believe me, but there are some horses I've treated where it was necessary to take like nearly a third of the third phalange at one time, and the horse is completely normal afterwards. But you need to stop the osteitis and the necrosis of the bone. Again, you need to go a little bit further than what is dead, so that the normal bone, with all the little capillaries and all the vessels, can help to destroy the bacteria, etc., so that you have normal cells who are there to start the new healing process. So don't be afraid to remove a part of the third phalange.
Indica que incluso cuando ha llegado la lesión al hueso, no tenga miedo de remover todo lo que esté necrosado, ya que si es que se queda, incluso él ha tenido un caso donde removió hasta un tercio del hueso, y eso es importante porque si queda materia infectada, esta infección va a volver en el futuro.
After that, you need to do a good bandage. The first bandage should always include a plastic bag, something, because it's a foot and it's in contact with the floor, and the horse urinates, you have feces, etc. So you need to include in your bandage a plastic layer, and then call for the next few days, you can call the farrier to help you to make a shoe with what we call an orthopedic plate with screws here. And in fact, it's very easy. The farrier comes, he's doing a shoe at the size of the foot, and then you have the plate that you open, you treat and please put it back, open, treat it back, and so you can do local treatment until complete healing for the next few weeks.
Él recomienda que siempre se debe poner una bolsa plástica, ya que el siempre va a estar en contacto con el suelo, se va a ensuciar. Incluso recomienda que se haga como una herradura especial, una placa que permita removerla, hacer la curación y volverla a poner, que va a ser una placa ortopédica especialmente para el caso.
Just here a little word about another disease that induces abscess, either subcellular or ufol abscess. it's the keratoma. And keratoma, it's a local tumor of the keratinocyte, okay? And it's like a big, you see that's a keratoma, it's white and it's, you know, like a keratin tissue. And it induces abscess, resident abscess. So when you have this, you need to put a tourniquet because it's going to bleed a lot. Okay, you put a tourniquet and you resect the wall and remove all that white stuff, all the keratome. And very often the keratome starts nearby the coronary band. So what I recommend you when you have these cases, instead of taking all the wall away, you remove a big part of it, and then here you do a trephine hole. And then you can from there curate, remove all the tumor, and it give you still here a stability with a piece of wall that holds the whole hoof together. Okay, it's a nice way to have a stability of the region. And then what I do, because I love these maggots, you know, we talked about that yesterday. I put some maggots for 3 days in it, and they will clean for me properly. And then you have the granulations tissue that's coming in the next 4 days, 5 days. But of course, you don't have to put, you can do it without the maggots, but the maggots help you to go faster, I think, in this type of treatment. And that's how it looks like, you know, after 3 days. And then you put a shoe with resin on top, and then progressively, every 3 to 4 weeks, you ask the farrier to come and we cut, and you know, the horn will come down slowly, and he's redoing the shoe and the resin. That's what it's all. Good luck. You were not there yesterday, you see, yeah?
No.
Yeah, yesterday you talked about that.
No. Es un tipo de neoplasia que se llama keratoma, que es de las células del casco en sí, de la queratina. Lo que hace es, bueno, produce bastantes abscesos y lo que él indica es que muchas veces lo que siempre se tiene que remover esta keratoma, se recomienda poner un torniquete porque a la hora de remover esta lesión va a sangrar bastante. Dice que no tengan miedo de remover todo esta neoplasia, pero es muy común que se encuentren el absceso, se encuentre también comprometiendo la manera vertical o longitudinal del casco. Entonces dice que dejen un pedazo, una porción del casco en la parte superior y que remuevan el resto. Me bromeaba de que bueno, yo no he estado en las charlas, pero le gusta utilizar larvas o gusanos, ¿no? Para que ayuden a comer la materia la materia podrida, todo lo que está muerto. Lo que él sugiere es a la hora de poner proteger el casco con resina y igualmente hacer una planta ortopédica y para que permita seguir haciendo el tratamiento y controlando cómo va comiéndose el material necrosado dentro del casco, y el casco va a seguir creciendo hacia abajo. Entonces esa nueva planta o esa resina que se le va a colocar va a tener que ir cambiándose a medida que el casco vaya creciendo y bajando.
And it's important to do that every 3-4 weeks.
Y es importante hacer este cambio de...
Yeah, I know. I'm learning with you. Look, yesterday. I did very good.
Se tiene que hacer este cambio de las resinas cada 3 o 4 semanas.
So never forget that always, because it's a mistake from the vet, if he has not been vaccinated for tetanus. So if it's not, you need to do it, because you have an open wound there, an abscess in the foot is an open wound. Usually NSAIDs, so non-steroidal anti-inflammatory drugs, are not necessary more than 1 or 2 days maximum, because usually as soon as the abscess is open, the pain goes away. And as I said before, I don't use very often systemic antibiotics, and if I do, it's mainly metronidazole. In case it really smells the anaerobes inside, then you just put the powder locally, and you just do 1 or 2 days maximum, and then usually the bacteria are dead. And eventually also, if I have some edema coming up under the skin, then I give penicillin a couple of days. But again, as soon as it's open, you have drainage, and then antibiotics are not necessary anymore.
Primero dice que es necesario siempre, sería culpa del veterinario si el animal no estuviera vacunado contra el tétano, ya que todo absceso es una herida, considera una herida abierta. El uso de antibióticos no esteroideos debe ser de 1 a 2 días máximo, no se recomienda más, sobre todo porque una vez que el absceso se abre, el dolor se relaja, ya deja de haber dolor casi de manera inmediata. Y los antibióticos, una vez más, dice que no usa mayormente antibióticos sistémicos, sino de manera local. Lo que él normalmente usa es metronidazole.
Now, once you have, like in this case, the granulation tissue that is present, then you can put some iodine 3%, so that's diluted iodine. Iodine tincture is much higher concentration, so you should read on the bottle, you know, your concentration. You bring it down, and you can do like 2 or 3 days, but not more than that, to help to dry the tissue and enhance the conification. So not more concentrated and not more than 2 or 3 days, otherwise you're going to burn the granulation tissue. That's not what you want to do. And if it burns, it's dead tissue, and then you're back to an abscess. Okay? So just enough to dry and to make a very fine pellicle of conified tissue.
Él explica que para el tejido de granulación lo que recomienda es usar una solución de yodo del 3%, pero que sean bastante cuidadosos de que esa sea la proporción, ya que de otra forma podrían quemar el tejido y causar una lesión y podría volver al absceso. Y esa solución de yodo del 3% ayuda a secar el tejido y mejora, impulsa la conificación de la herida.
Evolution of a normal abscess. Usually in 10 days, you have something yellow-brown, which is the new sole. So that's a normal healing time. If the corion, so the deeper aspect of the wall was destroyed, then you will first have that granulation tissue pink, like I have seen before, and then slowly you have epithelialization from the surrounding tissue, which is white.
Normalmente la evolución de esos casos es que solamente se trata del corion, se va a encontrar una nueva suela de 7 a 10 días que se va a dar un color marrón, claro o amarillo, y si es que ha habido mayor compromiso del corion de la parte interna, entonces se va a encontrar el tejido de granulación que ya explicó, se ve de color rosado, y la epitelización de la zona se va a ver de color blanco.
Usually, the evolution, subcellular abscess, you have an immediate recovery, so usually it's not lame the next day. With hoof wall abscess, it takes 3 to 4 days so that all the symptoms goes away. And it's quite often, I put sometimes, in fact, it's quite often, you need to reopen after 2 or 3 days because it's closing too fast. So you have to reopen. You know, it's a little bit like when you do a castration and when it closes too fast because you don't wall the horse properly. It's a little bit the same. The wound has a tendency to close faster from the top and not from the depth. So it's always important that you have the cicatrization that comes from the depth and goes superficial, than the superficie that's closed first.
En el caso de los abscesos de la cera, bueno, siempre la recuperación, los signos causados por el dolor se van de manera casi inmediata. Cuando se trata de abscesos de la pared del casco, normalmente se demora 3 a 4 días y es necesario volver a abrir esta lesión, ya que, como había mencionado antes, la cicatrización se va a dar normalmente, no se va a dar de manera igual, sino que el tejido que viene desde el fondo, desde el fondo de la lesión, normalmente se demora más. Lo que uno quiere es que sea de manera paralela, entonces es probable que se tenga que, después de 2 o 3 días, abrir de nuevo la lesión para que la cicatrización sea pareja.
The next line is total time for healing is usually 4 weeks, and that's most of the cases, it's 4 weeks. But I put to 1 year. And it's because it's these few cases where you didn't know exactly the origin of it. So most of the cases we are confronted to are nails that are the source of the abscess. But then you can have other diseases that are at the origin of the abscess. And as soon as you have a recidived of an abscess at the same location, try to understand what is happening with that horse. Is it a Cushing problem, because it's an old horse? Is it a keratoma? Is it melanoma? So you have many other options for recidive. It's not normal to have recidive of an abscess at the same location. So that's usually not traumatic, that's what I mean. Okay? So if a horse comes back in the next 2 months with a recidive at the same location, usually it's not the shoe, it's not the farrier, it's not a trauma, it's something else.
Indica que normalmente el tiempo que se demora en curar es de 4 semanas, pero él menciona que hasta 1 año. Y es importante considerar que si es que el caballo, el animal vuelve con un absceso en exactamente el mismo lugar, probablemente no hemos dado con la verdadera causa. Muchas veces se atribuye a algo traumático, por un clavo, etc. Pero si es que el absceso vuelve, por ejemplo, 2 meses después en el mismo sitio, tendría que considerarse si de repente es un keratoma, un melanoma, algún otro tipo de lesión que está originando el absceso.
But in general, hoof abscess is a good to excellent prognosis. Okay, so it's worthwhile to treat it properly.
Normalmente vale la pena tratar estos casos porque hay un buen pronóstico.
The prognostic is completely different now if we are in front of a penetrating injury of the foot. And the first thing you need to understand is that when you have a needle or nail that is like in this case, in the foot, you should tell the owner first not to walk the horse, not to remove the nail, and put, you see, something in front and so around the nail. Okay? So even if you go to the farm or the place where it is, you protect the nail around so that it doesn't go deeper. Okay? Every time it goes on the floor. Why? Because you want to know the direction of the nail inside and try to understand the structures which are involved. And so you need to do minimum 2 X-rays. 1 X-ray will tell you if the nail is going forward or backwards, and then a dorsal skyline view will tell you if the foreign body goes more medially or more laterally. And you cannot imagine the number of foreign body that goes into the foot that also will bend. So it's not because it seems to have a good direction from outside that it goes straight in a line. Usually because of the pressure when it goes onto the floor, it bends that object or that foreign body, like in this case. So it's very, very important. Now, in some cases, the clients or the people have taken the foreign body, So that what you need to do then is to put a catheter, like I've done on the previous picture here. You put the catheter in the hole, okay, that was made by the foreign body, and you inject contrast fluid. And then you see in this case that definitely the foreign body went deep into the joint, the navicular joint, and also B2, B3, because you have the liquid all here. That's the contrast liquid. So all structures, little structures here have been involved.
Explica que es muy importante cuando se presentan estos casos decirle al propietario del animal que uno, que no haga que el caballo camine, y dos, que no saque el clavo o la estructura que se haya clavado dentro de la pata. Esto es importante porque uno quiere saber la dirección que ha tomado el clavo o cualquier cuerpo extraño que se haya clavado en la pata. Es muy común que a la hora de entrar, digamos un clavo, este se doble. Entonces es necesario que a la hora de realizar, es necesario realizar dos radiografías, una skyline y una lateral. Esto para ver si es que efectivamente se ha doblado o si sigue su curso recto. En el caso de que el propietario haya quitado el clavo de la lesión, lo que se puede hacer es poner un catéter e inyectar una sustancia con plaster. Entonces eso me va a decir qué trayectoria ha seguido el cuerpo extraño.
With penetrating injuries, it's not a question to do or not to do local regional antibiotics. You need to do, you have to do. That has increased dramatically the prognosis. If you look in the scientific paper before we were using that technique, before and after, we went from 20% success to more than 60-70%. Okay? So in all cases, you need to do local regional antibiotics. What I usually do, I do the first one in general anesthesia, so that I do a good debridement, deep down to the joint or the flexor tendon if it's involved. I repeat the local regional antibiotics the next days standing, so I do 3 days successively, then I stop 1 day, and I do another time the 5th day. And why I do that? Because usually before I do my injection on the 5th day, I do also sampling of the synovial structures to see if we are fighting still against the bacteria or if we are winning. Okay, so we have an assessment of the synovial fluid. Okay, so usually at minimum 3 days consecutive. That's the minimum.
Es necesario usar antibióticos locales en este tipo de lesiones y siempre es necesario hacerlo por lo menos los 3 primeros días seguidos. Luego se puede esperar un día y efectuarlo de nuevo el 5.º día, y eso se hace porque en este 5.º día él hace una aspiración, toma una muestra de líquido sinovial y ves cómo está desarrollándose la infección, si es que todavía hay bacterias y se necesitan más antibióticos o si ya está mejor.
The debridement period is very important, and as you see, the debridement of a lesion around the needle should be the biggest rectangular incision is at the sole, and in every layer of tissue you do a smaller rectangle. Again, it's the same theory as we said before. We want after that the healing to come from the deep tissue, and so that's why you open more superficially, so that it doesn't heal faster. So you can probably see here the sole here, the opening. Then I go down to the fascia above the digital flexor tendon. That's a digital flexor tendon that was involved. I just cut a part of it, and that's not going to go down there.
Sugiere siempre a la hora de debridar se haga de manera rectangular o en forma de pirámide, ¿verdad? Los tejidos que están más distales, él hace un corte mucho más grande y a medida que va profundizando que mencionaba anteriormente, que queremos que la cicatrización sea de manera pareja. Entonces, al hacer un hueco más grande en las zonas distales, eso va a hacer que se demore más en cicatrizar y va a permitirle a los tejidos que están a mayor profundidad, les va a dar tiempo para poder alcanzar la cicatrización de las partes distales.
After that, again, what is important is to put a good bandage, change the bandage, and follow up like we did for the subsolar hoof abscess, and same thing. And what I want to show you here is the way we put the different shoe. That's the side where you have the abscess. You see here the screws and knees and the plate around the Lepage shoe. And it's very important that the farrier puts some product here. And it's a soft product that will close the back of the shoe so that no foreign body can go inside. So you have a good occlusion of the foot. And then every day then you can just remove the screws, the plate, do the treatment. And on the other side, because of the screws, because of that type of orthotic shoe, you have like a double shoe, I would say, okay? Because you have like 1 centimeter of screw. So it means here, to have a good equilibrium, you need to build a double shoe on the other side, okay? So that you don't have a horse that is like this.
Mencionan, esas son las placas, las armaduras de las que hablaba antes, que tienen tornillos y permiten que se pueda sacar la armadura fácilmente, analizar la lesión y volverlo a cerrar. Indica que es necesario, como estos tornillos tienen alrededor de 1 centímetro extra de altura, en el miembro contrario se tiene que hacer un zapato, una armadura que también tenga la misma altura para que el caballo no tenga dificultad de caminar.
And you see here on the right part of the slides that's the same foot, like a week later or 5 days later, I don't remember. So you have the shoe here, that's where you put the screws on. And you see the nice granulation tissue now covering the natural bone, covering the deep superficial tendon. And you already start with epithelialization coming from the white thing here, that's coming on top. But I just hope that the epithelialization doesn't come before the pink tissue is at the level.
En esta fotografía se ve esta herradura especial en los huecos que él señala, es donde van los tornillos, y en la lesión en sí se puede ver el tejido de granulación que está rosado y la epitelización que está de color blanco. Y una vez más se espera de que la epitelización no termine, esa herida, ese tejido no termine de cerrarse antes de que los tejidos rosados más profundos lleguen a cicatrizarse por completo.
Other type of shoe you can find, okay, with the plastic here, so there are different options that exist. I'm not going to stay longer on this. Evolution of penetrating injury. Usually you have granulation in 1 week. Frequent euthanasia after 2 or 3 weeks treatment. So it goes like this. And if usually after 3 weeks the horse is better and you are winning, then it can go back to normal life and sometimes normal sports. It takes about 4 to 5 months, so it's 4 to 5 times longer than a normal abscess. But again, as I said before, when I did my studies, and I was an intern, even a resident at the beginning, it was still a 20% success. So when orders were coming to us, there was a nail down to the deep flexor tendon. We told them 1 chance on 5 that you would still be alive. Nowadays, it's 3 chance on 4, approximately, that you will come back to normal if you do everything what we have seen today.
La evolución de ese tipo de lesiones es, dentro de la primera semana se da la cicatrización anulación, el residuo de anulación. Anteriormente, en el pasado, las probabilidades de que un caballo se recupere de ese tipo de lesiones eran alrededor del 20%, pero hoy en día las probabilidades de que, lo que se le hizo, las probabilidades de que no tenga que eutanasiarse el animal después de 2 o 3 semanas es de 3 de 4, es decir, 3/4 de probabilidad de que se sane. Y la cura o la resolución total de la lesión será de 4 o 5 meses.
Okay, I think we have to stop here. Any questions about that subject before we get to the 15 minutes stop? We will stop for half an hour before we start again. Do you have any questions?
¿Tienen una pregunta antes del proceso?
Okay. So, let's go for this last presentation. A few words about laminitis. Laminitis, as you know, you can do a congress on top of it. You can talk about. Means that we still don't know exactly what's happening, and we still don't have a good treatment for it. And that's why there's so much discussion. And I'm not going to make a long discussion, I'll just go straight to a few things, basic principles on how to treat laminitis.
La laminitis aún genera bastante discusión, sobre todo para obtener unos resultados, una curación satisfactoria, entonces no va a entrar en tanto detalle.
So in fact there was in the last 15 years 2 big theories that came one after the other one, and in fact the actual concept is that both theory comes together, so both theory are good when you have laminitis. One is the hemodynamic theory, which means implication of the vessels that will induce ischemia, and the second theory is the production of an excessive stimulation of some metalloproteinase, which induce destruction and death of the tissue. So both theories are good and both arise in a laminitis problem.
Explica que anteriormente se tenían dos grandes teorías sobre el por qué se produce la laminitis. Hoy en día ambas son aceptadas. La primera es la teoría de la hemodinámica, que indica que por alguna causa o enfermedad se produce un tipo de isquemia en el miembro. Y la segunda es la teoría de las enzimas, que dice que debido a una producción excesiva de esta enzima se produce la laminitis.
And as you see, the two first words here is various disease that will produce these vasoactive components or produce these excessive stimulation of metalloproteinase. It means that it can be colon torsion, it can be excess of grain absorption, it can be placenta retention, so various things can induce this. So at the end it's the same problem.
Indica que pueden ser varias causas, no necesariamente pueden ser varias enfermedades, que pueden ser incluso metabólicas o nutricionales, que al final van a producir la opresión muscular o el exceso de metalloproteinasas, que son esas enzimas que causan la laminitis.
So what's happening both pathologic process will induce cell death and then a breakdown of the bound, the bound between the hoof wall and the pedal bone. And you all know that laminar problem, you know, the lamina that should normally stick well together, and in fact it doesn't stick together, and then you start to have these the air coming in between, because that's dead, it doesn't attach together, and that's how the bone will progressively rotate or eventually sink.
Explica que tanto por la isquemia o por la producción de esas enzimas va a haber una disociación, una separación de la lámina con el hueso. Al haber esa separación, ese espacio, el hueso va a retar, causando la enfermedad.
So we talk about two types of laminitis. Acute laminitis that usually arise in 3 days and very fast you have a process going on, or a chronic laminitis that's usually a mild acute laminitis that is repeated every 1 year or 2 years, and then you have, or sometimes every 2 or 3 months. So usually it's a more, it's not a very strong laminitis, but it's one after the other one. So that's the two big options.
Las dos grandes tipos de opciones de tipos de laminitis que se pueden dar es la aguda, que se da una lesión fuerte dentro de las 72 horas, o puede ser crónico, que son varias seguidas pero de manera leve.
Usually you have two other types of clinical laminitis. You have the generalized the four legs laminitis or the contralateral laminitis. What means contralateral laminitis? It's a horse, for instance, who has a major problem on the front fetlock or the front leg, anywhere, any place. And then because it's very lame there, he put a lot of power on the other side, and then it induces a contralateral laminitis. And that's something in my hospital that we have a lot, because we have a lot of very difficult cases where we try difficult surgeries on fractures, etc. And so in hospital setting, we often have, well, in fact, we have more contralateral laminitis than generalized one.
Se puede dar de dos formas, en los cuatro miembros, en las cuatro patas del animal, o hay una laminitis que es contralateral, que es cuando hay algún tipo de cojera, algún tipo de lesión en una pata, y debido al exceso de peso o de fuerza que se tiene que ejercer en la pata contraria, se produce en esa pata contraria la laminitis.
And when you have a contralateral laminitis, it's always acute and always of a dark prognosis, because it goes very fast.
Normalmente esta laminitis contralateral es aguda y tiene un mal pronóstico.
And then after that, we said that before, you may either have a rotation or a dropping, sinking of the pedal curve.
Y bueno, debido a eso puede haber la rotación del hueso o una caída, ¿no? del hueso.
Okay, so to help you in the diagnosis, clinical diagnosis, I think you all know how to recognize that, because it's things that you learn everywhere in the world. But what can help you now to decide how bad it is or worse it's going? It's as soon as you have the suspicion diagnosis of a horse that is a horse or donkey that is doing laminitis, you should do X-ray, lateral projection of the foot, and the best is to do straight away the 4 feet, except if you suspect a contralateral one, because there is already a big problem at one leg. Normally you do all 4 feet, that projection, and I'll show you what to do with this.
A la hora de hacer el diagnóstico, lo único que va a sugerir es hacer una tomografía de los 4 miembros, siempre una vista lateral, y
So what you need to do when you do the X-ray is to glue or to fix on the dorsal aspect, starting exactly at the coronary band. You attach a metallic piece of wire or something like that, something that is a marker for the X-ray. Then you do the cliché, the X-ray, and you assess it. And what you need to do is to measure here at the coronary band between the hoof wall and the pedal bird, and also distally at the apex of the pedal bird and the hoof. And the distance here and there should be the same because both lines should be parallel. And you can see on this X-ray here on the right, that's a horse with rotation. The distance here is smaller than the distance here. It's very evident. And you can also see some hair in between the black hole there. That's the first thing. That's very easy when you have a rotation. Now at the same time, you need to know, is there a sinking process, a dropping process? For this, you need to make the measurement between the coronary band and the extensor process of P3.
The coronary band
And the extensor process of P3, of pedal bird.
Lo que él recomienda es a la hora de tomar la radiografía se ponga un cable o alguna estructura en la superficie del casco que me permita tomarlo como referencia, obviamente metálico o que sea radiopaco. Y en la radiografía lo que se va a medir es la distancia desde el hueso pedal hasta este marcador, alambre que se puede poner en la superficie del casco. Se tiene que medir de manera distal y de manera proximal. En la primera foto se ven las dos flechas de color rojo. Una es, la distancia del hueso al marcador metálico tiene que ser la misma en la parte de arriba, en la parte proximal y en la parte distal. Si es que hubiera una rotación del hueso, como es en la imagen de la derecha, se puede ver que la parte superior está más cercana que la parte inferior. También se puede ver que hay un vacío en la imagen. Y lo segundo que se tiene que medir es donde empieza el hueso pedal con la banda coronaria. Se tiene que medir la distancia entre uno y otro.
So this distance here is in one-plus and normal horses. That distance should be less than 10 millimeters. And in ponies, in ponies it should be less than 7 millimeters. So if the distance is bigger, it means that you have a sinking problem, or dropping problem.
Indica que si es que la distancia entre la banda coronaria y el proceso del hueso distal en un caballo debe ser menor a 10 milímetros y en un pony tiene que ser menor a 7 milímetros. Si que la distancia fuera mayor, entonces hay una caída del hueso.
If the dorsal thickness here is higher than 20 millimeters, it might tell you eventually with a horse with clinical symptoms that you already have like edema and that you're in the early process before braking and rotation. So you can have still two parallel lines between the horn and the pedal bird, but if the thickness is increased, it can tell you that something is going on there and that you should do another X-rays like 48 hours later and see how it goes.
No solamente señala la parte de las flechas rojas, la distancia entre el hueso y el marcador, es decir, donde termina la lámina del casco, no debería ser mayor a 20 milímetros. Si fuese mayor a 20 milímetros me sugiere que podría estar iniciándose un proceso de separación. herramienta es volver a tomar una radiografía 48 horas después para ver si es que se está separando, si esa distancia está aumentando o sigue igual.
These distances are not good for draft horses, so you should not rely on these numbers for draft horses. It's different, so don't take these data to assess laminitis in a draft horse. Heavy horse.
Esta distancia no es la misma para caballos más grandes, caballos de trabajo, solamente caballos de carrera.
So that's a good tool you need to really do. Every laminitis, do that X-rays because if you have a lot of rotation or if you already see that the pedal bone is going through the sole, then you know the prognosis is very bad. So that's very important at the first diagnosis. So the aim of your treatment should be based on relieve the pain, because if the pain stays in place, you have a vasoconstriction due to a neurologic reaction, and more vasoconstrictions induce more rotation, more death, etc.
Es importante para empezar el tratamiento manejar el dolor, ya que esto produce vasoconstricción, y si hay mayor vasoconstricción, la rotación del hueso va a facilitarse.
The second thing, you need to treat the underlying cause. So of course, if there is still a placenta, in the mare, you need to remove the placenta because you need to remove the cause of the laminitis.
Lo segundo a tratar es la causa de la laminitis, si es que fuera externa o si llegó reparido, saber tener la placenta, etc.
Third aim of the treatment is to prevent or limit the pedal bone rotation or dropping.
El tercer punto a tratar es prevenir de que siga rotando o hundiéndose, cayéndose el hueso, el pedal.
And fourth, to improve the blood flow to the foot, so to bring back the normal vascularization.
Y el cuarto objetivo es recuperar el flujo sanguíneo dentro del miembro.
So I would recommend that if you have any type of treatment, I'll talk about a few treatments after that, but I know they are full of treatments in the world. But if you have a few of your treatments that helps one of these aims, then you can use it. If it's an answer to these aims, then don't use it. I think so, but you need to try to find things that focus on this.
Hay muchos tratamientos para la laminitis diferentes, pero si es que el tratamiento que ustedes van a elegir abarca o promueve o logra una de estas cuatro cosas, entonces es un buen tratamiento.
And so probably you will not like me because I don't come with a recipe and I come with very, very old things. But you see, in the medical management, what we can use is phenylbutazone. It's very effective, very good, and give some phenylbutazone to relieve the pain and also work as anti-inflammatory drug. Also, we said we want to prevent or limit P3 rotation. We'll come with some shoes also, but something very easy is to have a deep bedding, and the horse by himself will do underneath him the best shoe, that fits to his pain at that moment. It will reduce the pain, and at the same time, it will make like good shoes. So deep bedding is important. Restrict exercise at that time. I think it's not good to exercise at the early stage of laminitis. And then also, once you're still in the active process of laminitis at the beginning, when you have that important inflammation with production of MMP2 and 6, then to put cold water to reduce local inflammation is important. If you just put a little bit of ice, just at the coronary band, that's not enough, because you need to refresh the blood before it comes down into the foot. So now there are some materials that are on the market to refrigerate properly the whole leg, so that it's really cold when it goes down into the foot.
No tiene una fórmula exacta para tratar la laminitis. Lo que sugiere es dentro de los... Se pueden usar antiinflamatorios y sugiere que la fenilbutazona funciona bastante bien. Recomienda que haya que el piso del box donde está el animal sea bastante profundo, restringir el ejercicio y mantener el miembro frío, la sangre que circula fría. Y esto no solamente se logra poniendo un poco de hielo, sino recomiendo usar agua fría, o incluso hay ya algunos sistemas, como el que se ve en la foto, que sirven para refrigerar la pata del animal.
The orthopedic management, there also you need to have that's something also important. I don't know at all the relation you have here, vets with farriers. Do you have good relation to discuss about? Or do you have farriers first?
Yeah, well, we have farriers, but not professional farriers. It's a farrier that became farrier by radiation, like someone teach him.
I think it's very important that you try to work always with the same, and somebody that believes in you, understand you, and that you understand him, and that you work together, because you can help a lot. A horse with good shoes, you can destroy a lot of horses also with a bad shoe. So I think it's very important that everyone, every vet has a good relation with somebody who works with the shoes. So that's really something important. Again, I don't want to go too much in detail in that, because there are many different theories. But what is important is to trim and squaring the tube to reduce the lever effect of the ground forces. You should understand that if the tube is like this, go far, every time he puts his leg on the floor, that makes a lot of pressure there, and at the inside, when you have the rotation of the pedal bone that rise, in fact what you do, you increase the problem, because you know, when the horse starts, push on the tube, and then the pedal bone is inside, goes to the other side. So you increase the problem. So you don't want to increase the problem, so you need to remove some horn in the front, and in this case, these pictures, it's because there's already a rotation of the pedal bone. And then we come back to what we said before. We should go down and remove everything that is not in contact between bone and horn. And that's why sometimes we have to resect a lot until we see a good coaptation of the horn with the pedal bone.
Hace bastante énfasis que la armadura del zapato del caballo tiene que ser óptima, ¿no? Si no va a empeorar las cosas, y sugiere que siempre se tenga cuidado, se esté en contacto con las personas que están a cargo de realizarlo, de hacer el caballo, de hacer el herraje. Y esto es porque cuando el animal pisa, la punta del casco hace presión, el suelo hace presión hacia arriba, y esto hace que se vaya separando cada vez más del hueso. Entonces, lo que muestran en las fotos es que a veces se retira parte del casco de la lámina de la queratina, la parte de la queratina, para que a la hora de hacer contacto con el suelo no se empuje hacia arriba y agrave el cuadro.
Now, in some cases, when you have a very fast rotation of the pedal bone, like also an important one, like about 8 degrees or more in 24 hours. So it goes very, very fast. Something that can help is a deep digital flexor tenotomy. So you cut the digital flexor, because if you remember your anatomy, the digital flexor tendon comes and inserts himself on the back of the pedal bone. And so, in fact, the tendon, by tension, brings the pedal bone down, and so it increases the rotation. So in the cases where you have a fast and important rotation, you cut the digital flexor tendon.
Cuando hay casos que hay una rotación rápida del hueso mayor a 8 grados o bastante agresiva, lo que se puede hacer es una tenotomía del flexor digital. El flexor digital jala el hueso, entonces al cortar al cortarlo, entonces vamos a permitir que ya no esté agravándose el cuadro, jalando el hueso.
Okay, so any questions on laminitis? So it's really, again, try to have basic rules, apply them, do always the same treatment so that you are familiar with it. It's something like this.
Si utiliza algunos vasodilatadores.
Well, we used to try acid-promethine, but because that we thought it was good. But now there are a couple of applications that says it doesn't bring anything and might be worse, so we don't use them.
Solían usar acipromicina, pero en realidad no da ningún resultado positivo.
Ixosuprine.
Ixosuprine.
Oh no. It's oxyprine.
Why not?
Well, because again, it has been tried for a long time, and some research has shown that in fact it doesn't bring anything. So we have stopped to use it. It was used also for nautical syndrome for some time, and then in fact it doesn't really help.
And they just...
In fact, at the end, they are not being treated, it's a treat. That's why I tell you.
So you just put
Use cold water, the bedding. Sometimes it's very, very painful. We do ring blocks, but like for half a day, something like that, not more than that, to help. And then shoeing, good shoes, and then, of course, treat the origin. No, it has been. There also the last study is about. No, to be honest, that's an update presentation of laminitis. We did that work about 6 months ago to try to see what is at the end. What is good? Is it fraction heparin? There was a study from Liège, about fraction heparin. But at the end, if you look really, it doesn't bring something.
And DMSO.
DMSO, DMSO we use in every disease where you don't know what to do. And it smells a lot, so the others know that you're doing something. So it's not bad. I mean, again, it's not that it's bad, it's really great something. But DMSO in France is not authorized because it's cancerogen for humans. So if you use it, don't use it too much for you. And especially don't put it too much. Because I know some people do massage or uveitis, etc. But you put as much DMSO in the horse and you put it in yourself, and then you get cancer.
No lo usa y recalca que hay muchos medicamentos y tratamientos que hoy en día ya no se utilizan porque hay varios estudios que muestran de que en realidad no hacen ningún bien al animal, ¿no? O si no es incluso negativo, no le hacen ni bien ni mal. ¿Cuál era el que dijiste? El DMSO incluso tampoco se usa porque dicen que se ha encontrado que incluso puede ser cancerígeno puede ser peligroso para el veterinario. Y tampoco usan anticoagulantes en el tratamiento de la
Quitter? Just one slide on that, just to tell you, when you have a fistula there, at that location, and that in fact it's not an abscess. And that comes with, I should have put that slide before, it's a differential diagnosis of an abscess. It's it's like a few millimeters or sometimes half a centimeters above the coronary band. It is not an abscess. A coronary band, wall abscess, usually it's really at the first millimeter of the coronary band. As soon as it comes out of the horn, you have the fistulization. When it's above this, then you need to think about the quitter. So it means a chronic infection of the lateral cartilage of the pedal bone. Okay, so that's here. So that's the hole there, it's here. Okay, and it's infection or major inflammation that induces castration of that region. So what you need to do then in surgery, you make a flap of the skin, and underneath you just remove that cartilage. It's not necessary for the horse, so it bleeds quite a lot, but don't hesitate to remove that piece of cartilage. Okay? And then you suture the skin back, and there's a very good prognosis.
Esta enfermedad que vendría a ser la infección crónica del cartílago lateral del hueso pedal podría ser un diagnóstico diferencial de los abscesos porque se confunden bastante, pero hay que tomar en cuenta que se da por encima del casco en sí, por encima de la banda coronaria. Lo que sugiere es realizar una cirugía donde se extrae el cartílago, que no es imprescindible para el caballo, se hace un flap, se coge parte de la piel y se cubre la herida y normalmente tiene un buen pronóstico.
We have seen that yesterday. I'm not going to take more about laceration of the foot. I highly recommend when you have laceration of the foot to use the cast, because it's a so difficult place to immobilize and to keep it clean from the floor that I think the best treatment is to bring back the laceration to a certain way that you can put the foot in a cast for 2 weeks, 3 weeks, depending.
No va a verlo rápidamente, ya que se vieron las laceraciones, esas lesiones que se vieron ayer. Lo que él recomienda es enyesar el miembro para prevenir infecciones, que esté en contacto con el ambiente, etc.
And you see, coming from there to there in 2 weeks, that's quite a success, and this part will, without problem, continue to heal by a second intention.
En la foto de la izquierda, en la parte inferior, es como inicialmente estaba la herida. En la foto derecha, después de 2 semanas, se obtuvo esa foto y es bastante notable la mejoría.
Fractures. Fractures of the pedal bone. You have multiple fractures, and it's, if we talk between clinicians, this is what we call a type 1 fracture. It means that a fracture of the medial lateral of the P3, but that doesn't go into the joint. Then you have the type 2, like here, it goes into the joint. Type 3 is exactly in the middle and into the joint. So that's in the joint, that's in the joint. Yeah, sorry, okay. Sorry.
En la primera fotografía es una fractura del tipo 1, donde la fractura no llega a la articulación. La segunda, en el medio, sí llega la fractura a la articulación. Y en el tipo 3 está exactamente en el medio y también llega a la articulación.
A drawing here. So that's another. I just want to show that one, and then I'm going to do a drawing for the treatment. That's a type 4 fracture. Look, that's a fracture. That's OCD.
Es el tipo 4.
Type 4, of course, is the implication into the joint. Lameness is accurate. important. You do the X-ray, you see that. If you do a transaction, you know, when you buy a horse, sometimes people ask to make X-rays. If you find this, but the horse is not lame, this is just congenital. It's either a ossification center into the extensor tendon, or sometimes it can be OCD, but usually it doesn't move, it stays there, and it will not affect the horse. So you should make a difference, diagnostic difference, you see, between both. That's not, that horse, we just found that it was a high-level dressage horse, no lameness there, and it was supposed to be sold, and then they saw that, they were quite afraid, but not a problem, he was already at the Olympic level. And this is a fracture, but it comes also from acute lameness. It comes to you, acute lameness, you localize the problem, do the X-ray, and that's what you find.
Ese es el tipo 4, es una, la radiografía se ve de esta forma, pero recalca que algunas veces también se hacen radiografías de rutina y se encuentran ese tipo de vistas. No puede darse también por un proceso congénito o una osificación de los ligamentos, y la diferencia es que el caballo, cuando se trata de una fractura tipo 4, va a haber bastante cojera, el dolor va a ser bastante intenso, pero en un proceso normal, congénito, incluso crónico, no va a haber cojera, el animal va a estar normal, va a trabajar, puede correr y no hay cojera.
Now, all together, we have 7 types of fracture with all the treatments, but in reality, in the incidence, it's mainly type 1, 2, then some type 4, and then type 3. This is the most often one. So I show you what to do in these cases, because it's essentially a shoeing treatment. So a treatment with the shoes.
De los 7 tipos de fracturas, los más comunes son la 1, la 2, luego la 4 y la 3. Y más que nada, los tratamientos, lo más importante en un tratamiento es la herradura, el tipo de zapato que se le va a poner al animal.
So that's the pedal bone with the articular surface here, and let's do a type 1 fracture. We will have that a lot. Type 1 fracture, that's not into the joint. Okay?
Esa es la fractura tipo 1 que no abarca, ese es el hueso, lo que he dibujado con la articulación, y esa es la fractura tipo 1 que no entra a la articulación.
That's a type 2 and into the joint.
Es un tipo 2.
Now, if I want to treat these, what you need to do, and I'm going to make a representation laterally. Sorry. Is everybody able to see here, or I have to go down there? Okay, let's move down there. That represent the horn, that's the pedal bone. And let's have here our fracture. That's a type 1. We could have type 2 there, but we'll just, the principle is the same with 1 and 2.
Ese es el tipo que señala, es tipo 1, pero el tratamiento que va a representar ahorita se puede aplicar también al tipo 2.
So you have done your X-ray. You know exactly where it is. You show the X-ray to your farrier. What you do, you need to ask for a shoe that is let's remove this one at the moment.
Una vez que tienen la radiografía, la usan como para hacer el siguiente zapato.
Every time the horse puts his weight onto the floor, there is an opening. Maybe we can wait. No, just to stop the line there.
Maybe.
Maybe this. It might work. Let's see if I'm responsible of that. I'm not insured. Okay. So, you need to understand that every time the foot goes onto the floor, in fact the horn opens for a few millimeters. It's a fracture. Like any fracture, we want stabilization. So you ask the farrier to do, I just have two colors, so I'll do my shoe in red also. You need to do a neck bar shoe, a shoe that is closed. Okay? First thing.
Tiene que, lo importante, como se trata de una fractura, lo importante es inmovilizar el miembro. Entonces van a pedir un zapato, que es lo que está dibujando en rojo, que haga.
So, then you put the nails, and then the hoof, okay, already has some stabilization. Second stabilization, you want that it doesn't open too much. So you ask him to make here, in French it's un pinceau, I don't know the term, what would be the term in English, you know this? What's it? Pestañas. It's piece of metal there because it's okay. So you should do that on both sides of the fracture line and in the opposite side. And then eventually also here, that depends of what the farrier wants to do. Okay, but what we need to do is to stabilize this. The problem, that can induce pain here, because you still have the pressure going from up and down. So what you need to ask the farrier is to remove some horn here. Between these two pieces of metal here, there should be no contact. No contact with here. There will be pressure there, there will be pressure here, but not in regard of the fracture line.
Entonces son tres cosas básicas que tiene ese zapato. La primera es la estabilización como alrededor del zapato, la parte de abajo. La segunda son esas pestañas que crea hacia la parte de adentro, que van a evitar que se muevan de un lado para otro o de arriba abajo, y como eso va a generar presión en el casco, lo que se hace es se quita, se remueve un pedazo del casco, de la queratina del casco, para que las pestañas queden a ambos lados de la fractura. Entonces la presión cuando el animal pisa el suelo se va a dar en las dos pestañas que están a ambos lados de la fractura, pero no hay presión debajo de la misma fractura porque se ha limado, se ha quitado parte del casco en esa zona.
The next thing you do to reduce again the pressures and also to increase the comfort of the horse, you ask the farrier to put between the horn and the shoe a plate of leather or silicone. Okay, here.
Lo que se pone entre la herradura y el casco se pone cuero o silicona para reducir el impacto.
Last thing you ask is the front of the shoe here to make it like this. a rolling effect.
Y lo último que se pide es que la punta del casco tenga esa forma.
Rolling effect, roll.
Como para que,
Like a boat, it's like a boat.
Que tenga una forma ronda para que el casco pueda
Rolling.
sí, mecerse.
Thanks. Okay, so if you do all that, that's the best way to immobilize what's happening inside and to help the little bone to heal. Now, between type 1 and type 2, the other thing I will do, you can do, it's a lavage of the joint standing. Because with the fracture, sometimes you have a little piece of bone or cartilage that have been, floating into the joint, and then the best is to remove them by lavage, putting needles into the joint. If you're not familiar with that technique, don't do it because you may induce an infection. If you are familiar with it, if you are in good condition, it really helps to remove all these debris out. In some cases, it's not even necessary because the fracture line is very thin. It means that there has not been a lot of movements into the joint, and then it's better not to do it. With third type 3, that's in the middle, that's a bad. Okay, type 1 and 2, very good prognosis. Type 3, the prognosis is bad. Bad because you have always very fast, you have a movement between one and the other piece, and then you don't have a good continuity in the joint. So usually for these days, type 3, we put a screw. Okay? So today we just see type 1 and type 2, that's most of the clients we get.
Para el tipo 1 y para el tipo 2, a veces hay esquilas o pedazos de hueso o de tejido que entran en la articulación y lo que sugiere es hacer un lavado para que salgan todos esos restos de tejidos. Solamente lo recomiendo si uno está familiarizado con la técnica, si no, ya que puede ser bastante contraproducente. Y en el tipo 3, el tipo 1 y el tipo 2 tienen un buen pronóstico, pero el tipo 3 no tiene un buen pronóstico y lo que normalmente se hace es se pone un clavo, y esto es porque hay bastante fricción, hay bastante movimiento entre ambas partes y no much about type 3.
No, because we put a screw, and I think people will not put screws here, so it's not.
Ok, entonces en el tipo 3 se pondría un clavo, un tornillo en el casco.
Okay. Just last slide to show you the type of complications we may have. And the complications are mainly due when the coronary band has been involved in injury. And that will induce abnormal wound healing and abnormal conformation of the shoe after that. So that's a major complication when we have tooth problem. And the other complication eventually is the production of exuberant granulation tissue, and we have seen that yesterday. That's the main two complications we have. Now you should be aware that the healing process of such a case can take up to 1 year, and some horses can adapt very well to, I would say, a bad shape shoe, a bad shape. The form doesn't really mean something, and once it's healed, but it takes a year, the horse can become normal again.
Sí, existen complicaciones que puede ser desde que se deforme el casco del caballo, pero he visto caballos que no tienen mayor problema con un casco que no sea normal, ¿no? Que sea deforme. O puede ser también que el tejido de granulación sea excesivo, como se da en la foto donde está rosado.
Usually you need to put the orthotic shoeing to 4 to 6 months. You change every 4 weeks, of course. 4 or 5 weeks you change. But usually that immobilization takes long. If you do X-ray of control I would say it doesn't bring anything, because some cases will heal properly, but you will still find the line of fracture. It will just be consolidated by fibrous tissue. So it's not really necessary to do X-rays for the follow-up. It will not bring you anything, except if the horse is going worse, then of course you will need X-rays to see why is he going worse.
No recomienda el uso de tomar placas de rayos X en el seguimiento del caso, porque no me dice mucho, a menos de que el caballo esté empeorando, ¿no?
And we have to change the shoe before.
Claro, y el herraje, el zapato del caballo se tiene que cambiar cada 4 o 5 semanas.
Because you always need to adapt type the shoe so that the fractures increase.
Claro, porque siempre tiene que cambiarse este herraje porque va a tener que adaptarse bastante ajustado a la lesión, al casco del caballo. Entonces, a medida que el casco va recuperándose, va creciendo, entonces vas a tener que cambiar la herradura.
So, any questions on this part before we attack the last chapter of today, which is still in the same area, but
I've heard the humans, doctors use a little pencil of silver nitrate in order to reduce the granulate tissue. Do you use that in horses?
you would do that. I think you would put tens and tens of little nitrate, and usually what you induce is iron inflammation after that. So the fact to burn something will induce a reaction, chronic inflammatory reaction. So what you use there, that silver nitrate pencil, you can use it sometimes like when you want to stimulate an inflammation when you have an umbilicus, a patent umbilicus, and you want to close it, and then you can irritate that for 1-2 days. But more than that. So if you do more, then you have an excess of inflammation, and then you have infection, etc., etc. So, no, it's not good.
En el caso de excesivo tejido de granulación, no recomiendo el uso de nitrato de plata para quemar el tejido, ya que puede causar una lesión repetitiva.
Any other questions on that subject? If not, I've combined a few things that I was not able to tell yesterday. I will make a resume of that. And then I can't really see because there is a certain logic to talk about that chapter of wound dressing.
Va a explicar unas cosas que no mencionó ayer, pero que tienen bastante, ayudan a mejorar lo que va a explicar.
It's about the dressing. Yesterday we talked about all the wound healing, etc. And there is a concept of moist wound healing. We talked a little bit yesterday. I said when it's too dry, it's not good. You know, it's good that it stays humid.
Bueno, en el caso de las heridas, va a hablar de el vendaje, etc. Y bueno, que explica que no es bueno que las heridas sean, si bien no queremos una herida que tenga exudados, pero tampoco que esté muy seca.
And so that concept is, remember we talked yesterday with different type of debridement options. And one was it autolytic debridement. And so when you have an early wound, and if you do a concept where you leave, you allow to stay the exudate, the production, in contact, then in fact all the cells and the enzymes will make destructions and will make that autolytic debridement. And that's what we call autolytic debridement.
Habla de la debridación autolítica, que es cuando permitimos que parte del exudado de la herida reciente quede en contacto quede dentro de la lesión, y esto es porque le va a proveer de células en y factores químicos que permiten que se dé esa debilidación autolítica.
So what you need to think is that when you decide to apply, because you're able, you know, with the type of force, with the number of times you can go to see others, you want to do that moist wound healing consent. So you should, of course, not let it dry, and you try to have a good occlusion. And you see, you have that type of wound dressing that are in the market to have a perfect occlusion to the environment of the wound.
Recalca que hay varios productos, hay varias formas que se pueden usar para que la oclusión de la herida sea perfecta, que es bastante importante en esa herida.
If you decide to use that, the advantage is that you do it one day and then you go back again 3 days after or 4 days. You don't need to change the next day. Okay, you have a good occlusion, you leave it for 3-4 days.
Si hay una buena oclusión, una ventaja es que no tienes que regresar al día siguiente para cambiarlo, lo puedes dejar 2, 3, hasta 4 días.
The problem is that eventually, if you put that bandage on top of a major infection that you didn't debride enough by yourself, you know, just remove the dirt, etc., then you may eventually have bacterial colonization that can happen, and that's a complication. But altogether, it doesn't induce more infection. If it's just clean, then autolytic debridement will work perfectly.
Un problema de esto es que si es que no se ha hecho una buena debilidación y han quedado bacterias dentro, entonces va a haber una proliferación de estas bacterias. Pero la teoría, en lo que si es que no hay, si es que hay una buena debilidación, entonces no va a haber una infección, la debilidación autolítica va a funcionar.
Now, if we go to the, that was just a word about this. Now, if we go to the different type of dressing you can use, there's a wide variety, okay? And goes from just a normal 4x4 to nowadays the use of PRP. We said something yesterday. Now, if you decide to use, for instance, a gauze, it needs that the gauze, if you want that to keep it wet every like 4 to 6 times a day, you need to put saline in the 4x4 so that it stays humid. Now you can use, remember yesterday, you can use, for instance, hypertonic saline to increase that debridement, and you can put during the first day concentrated hypersaline in that dressing to accelerate the debridement and to kill bacteria.
Hay diferentes tipos de técnicas para lograr la oclusión. Se puede poner gasa, que se le pone una solución salina, pero tiene que mantenerse, hacerse seguimiento varias veces al día. Hay incluso una técnica donde se puede poner una solución hipersalina concentrada, y esto va a favorecer que haya una la debilidación autolítica.
So this is one type of what we call hydrocolloid occlusive dressing. So you have an inner part of the dressing, which is the thick absorbing mass. Then you have that more white stuff here. I don't know, but you see there are two colors. Yellow is in contact with the skin, and then fine white film on top that stops bacteria to get in. And you can use them in the early phase on a clean wound, as I said before, to prevent the eventual infiltration of bacteria's deep. And you stop it, that's important, you stop before exuberant granulation tissue. So as soon as you have this type of wound, you don't need to use it, otherwise you really stimulate exuberant granulation tissue. So that's already a little bit too late here.
Bueno, esa es una de las técnicas que usan, y ese es un vendaje que usa, se llama, usa un hidrocoloide, es una masa que en la parte amarilla que menciona en la figura de la izquierda tiene ese hidrocoloide que absorbe, va absorbiendo todo el material, los exudados, y en la parte de afuera, en la parte blanca, es una superficie resistente al agua que va a prevenir que entren bacterias y que lo aísle del ambiente. Este vendaje, este tipo para obtener la oclusión, se usa al inicio de la lesión en una herida limpia para evitar infecciones, y se debe descontinuar apenas se tenga lo que se ve en la foto de la derecha, si que hay un excesivo crecimiento del tejido de la lesión.
Just one word, we said before that, you know, if I use 4x4 like here with hypersaline, usually in most of the cases the pharmacies will sell you 7.5% hypertonic saline, which you can go to 20%. It exists in the niche field. So higher concentration, better it is, okay?
Cuando se usa la solución hipersalina, normalmente lo que uno puede conseguir en el mercado es de 7.5 hasta 20% de concentración. Lo más recomendable es una mayor concentración.
And remember, this is just to be used during the debridement period, so maximum of 3 days, big maximum. So it's 1-2 days, sometimes 3 days, usually after 48 hours you need to change wound dressing.
Solamente se debe usar durante la debilidación de la herida, que no debe durar más de 3 días, 1 o 2 días idealmente.
You have other type of dressings, that's these, which are impregnated with an antimicrobial agent. But these dressings have the tendency to dry a lot in contact with the wound, so you need to moisten with saline on top of the dressing. Okay, it's quite good. I use them quite often, especially when I think I was not able to properly clean the wound. Then you have different shape, size, etc. of these types of dressings.
Este es otro tipo de textura, vendaje. Este tiene un agente antimicrobiano que es bastante bueno. Lo usa sobre todo cuando cree que no ha podido tener una buena debilidación y que podría de repente generarse una infección. Lo malo es que a veces tiende a secar la herida, por lo que se puede aplicar una solución salina para prevenir.
You have the hydrogel dressings. These are just water with glycerin and vinegar. You can then have them in a gel, or you can have it like this, as a kind of sheet of paper, you know, that you can put like a gauze. And they are completely occlusive, these. And also they improve autolytic debridement. This is of course not occlusive when used as a gel, but as a gauze it's occlusive. And you change like the other one we have seen before every 3 to 4 days.
Este tipo tiene un hidrogel que es más que nada agua con glicerina y un polímero. Hay dos tipos. Uno que tiene el de la foto de la derecha, que es como una gasa que tiene este gel que permite una oclusión total de la herida, y en la foto de la izquierda también lo puedes encontrar en forma de gel, ¿no? En un chusguete, y claramente este no consigue una total oclusión a la de aplicarlo.
Semi-occlusive foam dressing, another type of dressing that we can use, are the ones as soon as the granulation tissue is formed, so the debridement is finished, granulation tissue is there, you need to put a non-adherent dressing on top. If you look with a microscope, if you continue to put 4x4 in contact of a wound where granulation tissue is, you remove the 4x4 and you look with a microscope, you have a lot of epithelial cells that you have removed and debride because it's too aggressive. So you should really put something that is non-adherent to accelerate and to help the epithelialization. So it's very important not to put something adherent.
Una vez que ya se tiene el tejido de granulación, es importante no usar o no se debe apuntar a tener una oclusión total, sino que debería ser una vestidura o un vendaje semi-oclusivo. Eso es porque cuando son muy agresivos, cuando están pegados a la lesión, a la hora de retirar la gasa o lo que se esté usando, se retira parte del tejido. Eso se puede ver de manera microscópica, pero no al ojo.
And I finish with this, because definitely today everybody talks about PRP or stem cells, and these are new approach that you can put into the wounds. But is it better or not? We did a study some years ago, and it has been published in international review. And in a clean, aseptic wound, it's bad because it induces external granulation tissue. But it is good if you have atrophic wound that doesn't work properly. Then, of course, it's worthwhile to put PRP in there. There are no publications, to my knowledge, nowadays in horses about stem cells. It's used now for people which have been burned, okay, and then they put a powder, like powder of stem cells on top, and it seems to have good indications. But again, we are very far from human medicine, and we cannot apply straight away the recipe. But probably in the next few years, things might come out, and maybe it would be of interest to put stem cells or PRP in some type of meat.
Habla de esas técnicas, el PRP.
PRP is platelet-rich plasma.
Es el plasma con rico en plaquetas, gracias. No se recomienda más que en casos donde han habido complicaciones. Es una herida que está estéril, no tiene infecciones, entonces no considera necesario. Y el uso de células madre se usa en pacientes humanos, sobre todo en pacientes con quemaduras, pero estamos todavía lejos de utilizarlo, por lo menos hoy en veterinaria.
Okay, so I'm getting okay, now let's go to the really last part, which is now on top of the wound dressing, on top of the work we have done. Is a good bandaging, good immobilization and transport of a horse in regime, emergency rescue and transport of an injured equine patient. That's now the goal of this last subject.
Esta presentación es la última fase, que ya se habla del vendaje en sí, el vendaje propio, encima de la anterior que estábamos discutiendo. La inmovilización del animal, del miembro, y el transporte del animal.
Basic guidelines. First, location of the wound will be a major factor in your decision. You understand, if the head trauma, your decision will be different than the trauma of the hoof or a hind leg. So, location.
Algo importante es localizar la herida, claramente si la herida es en la cabeza, el tratamiento y el manejo que se le va a dar al animal es diferente que si la herida es en el pie.
When you want to treat the horse, it's important to sedate him a little bit, sometimes to do good work. But remember, especially if the front legs are involved in the problem, then all these clinical sedation will induce an increased weight on the front legs. Remember, the head goes down and then you increase the problem. So You need to do it, but not too much and not for too long.
Siempre es favorable sedar al animal primero, pero tiene que tener en cuenta que no se puede hacer por mucho tiempo o mucho, ya que al hacerlo, por el mismo que el animal baja la cabeza, hay aumento de presión, de peso en los miembros anteriores.
Just want to come back to there. Please, when you work on the hind leg, if you want to do a bandage then, please attach the tail properly. I've seen one of my students many years ago who just by the tail came in and just cut the cornea of the eye. Because it's like cutting the butter with a hair. So when you work at the back leg, please, it doesn't take long, just attach it the time you do the job. Because the horse just, there's a fly, and if it goes in your eye, it really hurts. Okay? So be very careful with that. That's why I put that picture here.
Señala que no se olviden de sujetar o agarrar o inmovilizar en todo caso la cola del caballo cuando se trabaja con las patas traseras, ya que por cualquier movimiento de la cola podría lesionar al veterinario.
So, you know that you need to immobilize, so in your car you need to have all the material ready, scissors, etc. So you have everything with you.
Es necesario siempre tener todo el material en la mano, en el carro, etc.
The basic principle to do the bandage is always the same. First, put the dressing. Look at what I'm doing here. I'm making with this one. In fact, I have my dressing and my first layer of bandage in my hand, and with my finger of the other end, I do tock tock on the skin of the horse, because at that time he will remove his limb, put it up, and then if you don't do that, it means that we are putting the bandage, it means that the bandage is gone. Okay? So you need to go fast on him, tock tock, takes his usually moves his leg, and as soon as he comes back to normal, then you start the bandage. Okay? And that's why you need to. And then I have the second layer in my hand. The second layer is in fact a soft cotton to absorb the exudate that you put on around that dressing. Above this, you will then put a raw cotton that is soft and thick. That's for really padding, and also it starts really from the foot, that all the passenger region is inside, so that you can really avoid flexion of the foot, flexion of the fetlock. It helps the immobilization. And on top, you will put an adhesive wrap.
Señala que son básicamente 4 cosas importantes. La primera, cuando se pone la vestidura o los vendajes que estábamos viendo con gel, etc., es importante. Pero lo que él dice que hace es toca al animal como para que levante la pata, e inmediatamente después de que el animal la baja, ahí es donde uno coge la pata y pone la gasa. Esto lo hace porque uno tiene que ser rápido, más rápido que el animal incluso, porque puede quedarse uno con la gasa en la mano a la hora que el animal está moviendo la pata. Lo segundo es que pone el vendaje en sí de algodón. Esto es bueno para absorber los exudados de la herida. Luego pone alrededor algodón, que eso más que nada es para amortiguar la zona. Y finalmente pone el vendaje adherente, que es lo que va a evitar que el animal realmente flexione y mueva el miembro.
If there is some bleeding, do not clean the wound. Blood is cleaning the wound. So don't spend your time. At this time you're in an emergency, you want to treat it. You can clean it around the wound. You can clean eventually to remove the dirt in the hair and on the skin around. But the wound doesn't need to be clean, because blood is doing very well that job and push all bacteria away. Then the best is to put the baby diapers on top and use leg wraps, roll goes or bed traps, things like that. And it means that everywhere you can do to stop the bleeding by pressure. Sometimes you do a double bandage, the time if arteries are involved, and as soon as the bleeding is stopped by the clot, okay, the next day, one day after, because as we said yesterday, the clot is good, it's good things, then you change it after 1 day, because otherwise it's humid and you may have multiplication of bacteria. And then at that time, after 1 day, then you start to debride better or things like that. Okay, but in emergency, you don't have to clean the wound, but you need to, by pressure, control the bleeding. Don't try to find the vessel. It's very rare that you have a big artery. Of course, if you see a big artery bleeding, then of course you just clamp it. That's not very often the case.
Cuando tenemos casos con heridas sangrantes, uno recomienda limpiar la herida, limpiar la sangre en sí, ya que la sangre está limpiando la herida de bacterias y otros cuerpos. Lo que él recomienda es limpiar alrededor de la herida y se pueden usar pañales de bebé sobre la herida y vendajes, incluso dobles vendajes o vendajes intensivos para hacer presión sobre la herida y eso va a detener el sangrado. Si es que fuera que está sangrando, no recomienda preocuparse por el sangrado en sí, a menos que uno note que realmente es un sangrado de una arteria o algo más alarmante, ¿no?
Now, what are the materials you will use? We have been talking about wound dressing, we all know that. Then, on top of that, on top of the dressing, you need to have some soft material for external support. As you've seen, like baby diapers, different type of things. And then now you need also some rigid material for external support. Rigid can be a long piece of wood, can be a PVC, you know, these long tubes that only you put on the roof, you know, to collect the water, and we cut them at the size you need. So there are many different options. Even a piece of metal, like here, you know, we have fixed a piece of metal on top of a PVC tube.
Primero recomienda, como habíamos visto, poner alrededor del vendaje algo suave, como bebé, algodón, etc. Y en la parte externa poner algo rígido, que puede ser metal o incluso tubos de PVC.
So, last thing that you can use as rigid material, of course, is the use of different type of cast. Resin, no.
Y lo que también se puede usar como material rígido es diferentes tipos de yeso, que puede ser de yeso, de resina, etc.
Also, you need, when you do such a bandage or you need to immobilize, you need to prevent some complications like the horse who tries to eat his wounds, or you know, because it hurts or something like that. So there was somebody who asked me earlier, was you, what to do. That's something that is quite easy for preventing the horse to eat his wounds. It's a type of wood color. Also this, that you can attach to the altar. And then sometimes also we put some reagents, you know, like mustard or things like that under the bandage so that they don't like the products.
Una complicación puede ser que el caballo intente lamerse o comer parte de la herida, entonces lo que se puede hacer es, en la foto de la izquierda se ve que tiene un collar de madera que evita que pueda llegar a la lesión, o en la foto de la derecha tiene un recipiente de plástico que se asegura o se junta al halter. Otra cosa que también hace complementario es poner algo encima del el yeso o del vendaje que no le gusta al caballo, como puede ser mostaza.
Also, always remember that when you do a bandage, you may put too much pressure, and that's typically a complication. It's a pressure sore from a bandage. It will heal. Sometimes it will take time. Sometimes it will even affect the flexor tendon, and that's worse. And then usually when it heals, it will have wide hairs where the lesion was. One of the regions where it often makes problems, it's at the back of the carpus, where you have the accessory carpal bone that makes the preeminence. Bone is straight away underneath the skin, and that's a place where you often have these sores. So be very careful when you do bandages. You need to put a good pressure and also to protect every bone that is in preeminence.
A la hora de hacer el vendaje es importante poner algo que evite que se lesione la parte interna del caballo. Por ejemplo, a la hora cuando se pone el algodón, cuando se ponen los vendajes, ya que se puede crear una herida en la parte contraria. Sobre todo en la parte del hueso accesorio del carpo.
We have the material, we know how to treat the wound. Now, how should we immobilize it? Perfectly, because especially if you have a suspicion of fracture, it's always an emergency, because you need to prevent complications. And that early immobilization is the major factor on the healing process of the fracture later.
Siempre que se tiene una fractura, se debe tratar, es una emergencia y los primeros cuidados que se tengan con la fractura van a ser los más importantes.
Just a quick word, one slide. Look at that huge laceration here. Both senses are gone. Prognose, very good. Don't worry. Very small laceration, back from the fetlock, implication of the flexor tendon, guarded prognosis, difficult. Okay? Just to help you, it's not the size of the lesion that is important, it's the location and what are the tissue involved.
Señala que no es, lo más importante no es el tamaño de la lesión, sino la localización de la lesión. En las primeras fotos hay un compromiso de los ligamentos extensores, pero hay un buen pronóstico. En cambio puede haber como en las segundas dos fotografías, una herida bastante pequeña, pero es el ligamento flexor el que está comprometido, entonces hay un pronóstico reservado.
You should divide the legs of the horse by a different region to know how to splint properly. The goal of the lesion that is in region 1, that means either in front or at the back, starting from distal metacarpus, distal carpal bone down to the shoe. You need to align, that's a P1 fracture here. The goal is to align all the body columns of P1, P2 and P3 and to protect soft tissue from compression. So how do you do that? You need to apply such a splint on the dorsal part of the limb, for the front limb, and you raise a little bit the heels. If you see that thing that we have made ourselves in metal, there is an elevated heel here, and then here you have the dorsal splint. And then that's another type here that you apply. That's something that we did constrict with our fire, and that was homemade with straps, etc. But the principle is the same. Increase the heel, put the splint in front.
Estaba hablando en el slide anterior de una fractura del tipo 2. En ese tipo de fracturas, en esta región 1, que es la parte distal de los miembros anteriores y posteriores, lo que él recomienda es poner lo rígido del yeso, la parte rígida, que puede ser tubo de PVC o puede ser una vara metálica, lo que se vaya a usar, en la parte anterior del miembro, y elevar el talón del animal. Y en las fotografías muestran dos diferentes. El que tiene fondo rojo es algo que ellos mismos hicieron en el trabajo, y el otro es algo que tiene la misma función, pero fue un poco más improvisado.
If it's an hind limb, you put the splint not dorsal but plantar, and in both cases, front or hind limb, it should cover the entire foot, like here, to really, be good contact with the foot, and it should extend to the upper portion of the cannon bone, so it should go up to here, or there.
Si que se trata de una lesión en el miembro posterior, la parte de esa parte rígida debe estar en la parte plantar y debe cubrir todo el pie. Tiene que ir desde la base del casco en sí hasta lo que vendría a ser, creo que le llaman la rodilla. La caña, desde la punta del casco hasta la caña.
Now, concerning the region 1, you may find on the internet, or anyway, there's what we call the Kinsey leg saver splints, so you don't have to make them yourself. The problem is that they are quite expensive, but that's these Kinsey splints that you may find on the internet. Kinsey is because the name of the guy who's producing them. And you see, you have different sizes. You have the raised heel here, and the straps, and then ideally, you ask somebody to help you to put the leg up and put properly, you see, the Kinsey splint. So of course you don't have to build it yourself and you buy it like that. You have these for the front limbs, and that's for the hind limbs. You see, it's another construction, because this time it's made not to put the plantar splint like you do it yourself, but it's very rich. It's made, here in the front, and it's very much higher heels, and everything is blocked with different straps, so that it's well in contact with the bandage.
Este es un tipo que se puede encontrar en internet que se llama Kinsey. Kinsey es el nombre de la persona que crea. Se puede, el que estábamos viendo ahorita es para los miembros posteriores, pero en la diapositiva anterior estaba para los miembros anteriores. Se necesita que una persona te ayude para ponerlo, pero es mucho más práctico comprarlo, ¿no?
You can also, if you want, do a cast standing. You also need a help, and then of course, with the cast, you can do exactly the same by making an alignment of all the bone structures.
También se puede poner un yeso, que puede ser no el yeso en sí, sino de resina o de cualquier material. Y igual se aplica una varilla, un elemento rígido, una vez que se hayan alineado todos los huesos, ¿no?
Region 2. This region now goes to the mid-foreleg fractures, like here, that nice cannon bone fracture here, you see, there. And that region we want to prevent the lower limb from moving in the 4 directions, because in there you can go forwards, backwards, left, right, because what we want to do. So for this, you need to have 2 splints, and then you use these rigid material we were talking before. So here with the green lines here, the arrows, you have the caudal splint that goes from the ground to the top of the other column. Okay? And then we have a lateral one that goes also from the ground to the sides of the elbow. So 2 splints, 1 caudal, 1 lateral.
En este tipo de fracturas, que es en la parte superior, lo que se tiene que evitar es que los huesos se muevan en las 4 direcciones, de delante, atrás y lateral. Se usa pone caudal que va desde el suelo hasta el olecranon y la otra que va desde el suelo igual hasta el codo del caballo.
It's really important that those splints start from the sole, because otherwise if you put them higher, they will move down because they are heavy. So then immobilization is not good anymore.
Y es importante que empiece desde el suelo, ya que con el peso y con la gravedad, si que no se pone bien, esto va a bajar, y a la hora de bajar no va a haber una buena inmovilización.
If you work now with region 2, going up to the tarsus, from region 1 to the tarsus, you need also to apply 2 splints at right angles. In fact, it's just basic, remember your physical forces. When you have 2 splints at right angles, it's just reduce enormously the force on the bone or destruction on the knees. You put a caudal splint that goes from the ground to the highest point of the hock, and a lateral one that goes from the ground to the stifle. Now there is still also an option, like here, to put everything. You see the splint, it's inside, but instead of putting a bandage, you put a cast. So it's either a bandage or a cast, and you still have inside your caudal and lateral cast. Splint.
Y en estos casos se pone la estructura rígida, se puede poner en caudal que va desde el suelo hasta la caña. Y al lateral que vaya desde el suelo hasta la barbilla. Hasta la barbilla.
If you don't have a problem on the region 3, so it means from the distal radius or distal tibia up to the elbow or up to the stifle, what you want to do there is not to prevent movement in all 4 sides, it's to prevent lateral movement. Look at this. Nice tibial fracture. Here. Good distal tibial fracture. If you remember your anatomy, all the muscles and the tendons are in front, laterally, and at the back. And immediately, you can go with your fingers and you feel the bone under the skin. You have nothing there. When a horse has a fracture, there is a pain. And pain induces contraction of the muscles. By contraction of the muscles laterally, what it makes, it pushes the piece of bone medially. And that's the best way to have the piece of bone that will cross the skin, and then it's gone, because you have bacteria that is getting in, etc. So you go from a closed fracture to an open fracture. So your main concern is to prevent, in the front leg and in the hind leg, lateral movement.
En esta región lo más importante es prevenir el movimiento lateral de la fractura, y esto es porque los músculos normalmente se encuentran a ambos lados. Entonces, cuando hay dolor, los músculos se contraen y eso puede hacer que la fractura del hueso se mueva hacia el lateral, y si es que es bastante intenso, esto podría incluso hacer que la fractura vaya desde una fractura cerrada a que atraviese la piel y se convierta en una abierta, que es muchísimo peor.
So the best way to do that is to apply 2 splints at right angles. A caudal one from the ground to the top of the crown. You know how to do that because of region 2. But this time, the lateral one goes from the ground to the level of the withers, and that's the way to do it. That's the horse. You saw the slides before the fracture. That's this horse, and you see here, and that's the way you can apply, and you see it's very big. And so you use, in fact, the shoulder and the upper part of the limb, so that with the splint is not able to go laterally.
Y lo que se busca en estas fracturas es igual, se ponen dos fracturas rígidas. La primera es igual que en la fractura anterior, de manera caudal, desde el suelo hasta la punta del olecranon, y la segunda es lateral, desde el suelo hasta el hombro, que empieza la fractura del hombro.
And the same. Just one word about the fractures of the ulna, because that's quite a common fracture in a horse, ulna. And there's a little difference, is that in fall, it's better not to use any splint when you have a fracture of the ulna, because it's too, the splint, the bandage, are too heavy, and in fact you increase the movements of the fracture, so you don't use any splint with force. And otherwise, what I want to say, on the hind leg for each tree, you see, we have the same, this side, the lateral splint goes to the hip, and it's the hip who will propose to any type of lateral movement.
Lo que mencionaba es que en sillas no se utilizan, para la fractura de la ulna es preferible no usar estos yesos, esas estructuras rígidas, porque el peso va a empeorar la fractura. Y bueno, volviendo a animales adultos, en los miembros posteriores, la estructura rígida va a ir de igual manera que hasta el hombro, hasta la altura de la cadera.
And finally, region 4, which is a proximal limb fracture involving the shoulder or the upper part up to the coxofemoral joint. Like here, you see the fracture, you see all the edema and the blood coming down. In fact, you just don't do anything because it's even complicated because it's more weight, and in fact the muscle has the part that protects any type of movement there. So region 4, you don't do anything.
En las fracturas en esta región está contraindicado, no se hace nada, en verdad, debido a que los músculos protegen las fracturas.
So I try to accelerate because I know it's time. Five minutes. Okay, I just want to finish because I only have 5 minutes. Please just finish. Transportation. There are a few recommendations you need for transportation also. Just to remember, you can transport nowadays a horse, well not nowadays, but you might be eventually involved in some transport into an airplane and by boat eventually, so there is options. We'll also have these options for transport into cars or also helicopter transport. Just for your interest, it has been developed by the US Army during the war in Afghanistan because they were still using mules, and we use that frame, that thing. It's very well done, and we use that here, and we do 5 minutes. Okay, just 2 minutes. And that's another type of transport here that's in Switzerland for the mountains. It's ambulance for horses, but it's carried by horses, you see. So then they can go everywhere. But let's go now to really what is the best transport. The ideal emergency trailer. It should have a space to handle the horse from all sides and to adjust to the horse side. Have a non-slip floor. It should be more solid than normal transport, because if you have especially a colic or things like that, sometimes it just jumps right, left. So, and then if you need to transport a horse with a fracture, you need a strong frame and with a support on it like here. So that's the ideal transport. Inside it should be well ventilated, You should have a mat for recommend animal, a curtain when you go on the, for instance, on the racetrack and there is an injury, and if you want that the people doesn't see what you're doing, it's not very nice sometimes, if the horse is dying or a bad fracture, then as in this one you have a curtain, if you just come outside and somebody holds the curtain. A video camera for the driver, so that when he's driving, he sees if the horse is comfortable or not, and if there's a problem, probably can stop at any time. Of course, if the horse is laying under general anesthesia, somebody stays into the transport. Now, what is also that? Yeah, you want to translate? Is it necessary to translate? Yes.
Dice que tiene poco tiempo. ¿Necesitan que haga la traducción?
No, relax. I mean, I tried to finish these few things for the next minute. I don't know if somebody needs to take a place. Long loading RAM. And if you don't have a long loading RAM, try to have somewhere where you can reduce, the height of the floor to the ground. So that's very important, especially when the horse has a limb problem. Also, between the moment you put the splint and the immobilization, usually during the first steps, the horse doesn't like it. He wants to adapt. So just walk a few steps before pushing him in the transport, so that he just feels what is happening on his leg. Maybe you can translate that.
Antes de que bueno, primero que tiene que tener una rampa larga, si no hubiera una rampa larga, se puede tratar de evitar que el ángulo sea tan agudo, y antes de meter al caballo al camión, es bueno que el caballo dé unos pasos por sí solo, como para que se aclimate y pueda tener estabilidad antes de empujarlo para que entre el vehículo.
No, loading the horse should open all the doors so that he's not afraid. Put a maximum of light inside. And in fact, so everything is open, and then for the horse it goes easier inside, and progressively then you narrow the space when he goes in. As you see, the rope here is quite long, it's not too high, it's nice, and there is a door in front, and so that's very important when you want to unload the horse, and we'll come back to that later. Look at this horse. Importance of limb mobilization. This horse, look, the fracture is here. Look at the type of bandage was done. Now, we have talked together before. Region 1, 2, 3, 4, you should have that in your head. And as soon as you come to an emergency, properly immobilize. If you go in a transport with such a bandage, the transport can be very good, but at arrival, the fracture will be worse, because in the transport there is a lot of movement. Okay? So after that, slowly, once the horse is inside, then you will close the door in front. You will reduce the space with a partition of the stall, and then put the chest on. And that's a good transport in ambulance or the S direction. If it's a full limb problem, remember, if you stop your car, if you're on your floor, if you stop, all the weight goes forward. So of course, if you have a front leg problem, it's not good. So it means that ideally you should reverse the head, which is not always easy because you don't have a transport where you can do anything inside. Okay? But so if you have a front leg problem, the head should look in the other side. should we stabilize the head or not? You should not. You should give the maximum freedom of the head and the neck. It's the only option for the horse to stabilize himself. Okay, so you block the back part of the body, but the front part should be free. Concerning the body, the style position to confine, there are many options. So if it's a pony, you can put like straw on the side, etc. Do something smaller. Or like in here, that tray that in these big trays, you can have this style partition that really can squeeze the horse on the side. The head and the neck is free, but the body is blocked. If you don't understand something, you just raise your hand and then it will be okay. When you transport a horse in a supporting harness, you will do that if you have major injuries, so the frame can go then on the ground. You put the horse in the harness, and then you remove a little bit of the weight on the limb that is involved in the fracture of the tendon laceration. But in these cases, you need to have an experienced person that stays in the trailer with the horse, because at any time he can panic, and so you need to give sedation to the horse. But you see, even when you come out from the truck, the limb is not in contact with the ground, and so there is no problem of increasing the injury. To unload the horse, you should start with the sound limb first. So in the sound limb, either the front limbs or the hind limbs, that should go first onto the ground. Because then the horse uses the sound limbs to jump. Okay? And you will protect his